with us. I'll be introducing them as the program continues. So once again, you're welcome to this program, and we hope that we have an interactive session. We have good discussions so that we go out of here better informed about the conditions that we are coming to talk about. So without wasting much time, I would like us to call on one person who has been very instrumental in all of this, pioneering and starting with colleagues to make sure that today we are here to actually disseminate most of our findings and move this forward from just research into implementation. It is important that you understand that this started from the EPINA project, and so we are fortunate to have the global lead of EPINA here, and he's in the person of Professor Charles Newton. He will give us his brief remarks as we open the session. So, ladies and gentlemen, please, with a round of applause, let's welcome Professor Charles Newton.
Great. Thank you very much, Daniel, and thank you very much for everybody attending. So this program actually started in 2008 in Contampo when we did our, when I was fortunate enough to spend a couple of months up there doing a study on epilepsy in the Contampo demographic surveillance system. And it was from there that we began to realize that the epilepsy in particular was different across different parts of the continent. And the data that we were getting, the study that we were involved in 2008, involved 5 countries across sub-Saharan Africa. And we were getting different results across, even though from the different countries, even though that we were utilizing the same methodology. What we did do with that study, the SEED study, was identify the burden of epilepsy across the continent and the risk factors. And these, of course, differed according to the circumstances. So it was great when we managed to get the funding to have a follow-on study where we looked at translation research in the context of epilepsy. I see my slides have come up. Okay, great. Thank you. So, so that was the background to it. So this has been a long project in many ways, and Ghana has been very instrumental in developing and progressing this project in many, many different ways. One of the reasons that we came back to Ghana for the second stage of the project was, first of all, it was absolutely delightful to work with Patrick and Albert on the first project. Secondly, that they had done a demonstration project with the WHO in Accra. And thirdly, was that we wanted to, most of the work in Africa had been done in rural areas, and now we wanted to move into peri-urban and urban areas because that's where a lot of people with epilepsy now reside. So I'm just going to give you a brief background. So the epilepsy pathway innovation in Africa was really there to reduce, the main aim was to reduce the health burden of epilepsy, and in particular to improve prevention, the clinical diagnosis and the management of epilepsy, more of a translational research. And we chose the sites that we could do that. So in Tanzania, we knew that they had the highest incidence of epilepsy recorded on the African continent. So we went in there to try and prevent epilepsy by improving perinatal health services and also in controlling onchocerciasis, which we've hypothesized might be responsible for the high incidence. But we also wanted to embed in the program the oral histories, the lived experiences of people with epilepsy. And this has been a cornerstone of the work. And in particularly, I'd like to acknowledge Sabina for the immense amount of work that she's done in this context in Ghana, and that we've been able to replicate in all the other sites as well in this context. So we wanted to get what the lived experiences, what the people with epilepsy were facing and experiencing, to help us, to inform us in terms of the diagnostic tools that we're going to use. And so we utilize that information in order to develop apps to improve the diagnosis of epilepsy. Not only that, we also wanted to improve the management of epilepsy, and so we wanted to improve the adherence to anti-seizure medication through text messaging, which we conducted as a randomized control trial in Kenya. The other thing that we did do was we introduced the MHGAP guidelines in many of the sites in order to try and improve the diagnosis by primary healthcare workers as well. And then finally, what this program is about is really about the translation of this information and the work that we've collected here in Ghana and other places to try and inform the ministries of health of what is happening. So these were the sites that we chose, and these were basically based upon very specific characteristics of these sites. And as you can see, there were much more urban sites than we had previously examined in this context. And really, it was these are the four main things that we wanted to do: collect the oral histories of the lived experiences to try and inform us. To do the burden of disease, so the prevalence studies. So manual was particularly important in instigating the burden of disease in the peri-urban areas of Accra. What was reassuring was that was very similar to the work that we had done in Kintampo, showing that the prevalence was similar. So now in Ghana, we actually do have a really quite a good estimate of how much epilepsy there is in this context. I've already mentioned about the prevention of epilepsy, and we also developed dashboards to improve the monitoring of the diseases as well. So the app development, which really Arjun Sen led on, was really important in terms of trying to improve the diagnosis and make it easier, particularly for primary healthcare workers, in order to diagnose and do the initial management of epilepsy. I mean, there's just not enough neurologists or psychiatrists on the continent in order to manage all epilepsy. So it's important that we empower the primary healthcare workers to start off the initial diagnosis and the initial management, and then refer when there are difficulties in the context. So that's why we put a lot of emphasis on training primary healthcare workers. I think the other thing is that with Arjun and Helen Cross, we instigated the first education program of adult medicine. There's been a very well-established pediatric training in epilepsy, and this was taken forward, and this was one of the deliverables in this context. And I've already mentioned about the adherence project. I think the other thing is that we were very fortunate to work with very talented, bright people who are very enthusiastic across the continent, and whom we have managed to support the PhD programs, mainly and largely through the local universities. And so I think that this has been really one of the best outputs that we have, that we've actually hopefully infused the younger generation to take this work forward in this context. And this is really acknowledgement of the vast number of people that were involved in this program right across the continent, and that we were able to utilize in this context. And it's really the achievements of the EPINAR program are based upon all of these people who contributed so much. So without any further ado, I'd like to thank you for the brief introduction, and hand over back to Daniel.
Another round of applause, please, for Professor Charles Newton. So with a singular honor, I would like to acknowledge other colleagues for Professor Charles Newton from the Global EPINAR Project. So we have Professor Lee Sander, who is here. Prof, if you would just give us a wave. Professor Lee Sander, he's here with us. Thank you for joining us. Professor Helen Cross is also here with us. Thank you. And then Professor Arjun Sen, who is also here with us. Thank you. So the team is all here represented, and we are grateful for joining us. Now we would want to bring it home. So we've heard about the projects, the Global EPINAR projects, what's happened and all of that, and the big team that we have We want to narrow it down home for you to understand what is going on in Ghana, what has been achieved so far, and what are the ways, the steps that we need to do going forward. So without wasting much time, this is the time to call on the PI for Ghana and the program lead, Professor Patrick J, as he takes the podium. Thank you, Prof.
Thank you, Daniel. And Charles, we do appreciate such a wonderful overview of the project. And it appears I don't have much to say because the project has been really evaluated by Charles. Just as Charles said, this was one of the biggest projects in epilepsy in Africa, including Ghana. And you would appreciate from the number of people that were involved. And all the global leaders of epilepsy are involved. If you talk about International League Against Epilepsy, their president is involved. Our president, I mean not their president, our president. Global leaders in epilepsy, Professor Arjun Sen and Professor Lysander. And I think I will just say before I talk too much that Lysander was one of my supervisors in my PhD in the UCL. And Helen Cross was, I used to get to know her from the Attach Hospital, which was the Great Ormond Street Hospital for Children. And eventually she became the president of the International League Against Epilepsy, while Charles has been mentoring myself and Albert for such a long time. And interestingly, Arjun was finishing his PhD whilst I was at the UCL. So Arjun and I really go back, way back in those days. And it's good that we are all working together and bringing epilepsy out of the shadows in this our dear country, Ghana. It's a pity most of the for political leaders are delayed, but they say they are coming in, so we are waiting for all of them. This project, I don't need to talk too much about what has been said already. You know about University of Oxford, UCL, the main collaborators, and was sponsored by the NIHR. And the Ghana project was done in the peri-urban area, Shai Osudoku, Ningo Prampram district, which is just under 30 minutes from Accra. Those of you that have been to Ningo Prampram before, it's a beachside area, coastal side with very beautiful beaches, huge houses, and a very interesting mix of population. The Shai Osudoku is full of forests and all sorts of games in that area. So we had a rural setting and a peri-urban setting that we worked in. The study area is pictured here in a very nice way. The Dodowa Health Research Center remains the focus where the project was done. And as you all know, Dodowa Health Research Center is the second largest health research center under the Ghana Health Service. And they maintain a very robust DHSSS health system and surveillance site that monitors every individual within that area. That's Shai Osudoku and Ningo Prampram. It's quite extensive, extending from along the Dodowa through Asuchare through to the Ningo Prampram area. In Ghana, we were aimed to improve awareness, diagnosis, and care, reduce stigma of people living with epilepsy in southern Ghana. You all agree that stigma is a huge thing in this country with regards to epilepsy. And if we're able to capture the stigma and reduce it, we would get to controlling and getting a lot of people out of the shadows with regards to epilepsy. And also, we had an aim to get the prevalence of epilepsy in the Shai Osudoku and Ningo Prampram districts. As Charles said, this was with the background that what we had done in the rural area should be able to be mirrored within the region or the area. And if you get to know, once you're able to mirror what is in the rural to what is in the peri-urban, urban centers, then it gives us the right estimate or the fairly good estimate of what epilepsy is in the country. I remember when before we started the Kintampo project, it was always an estimate. The Kintampo project brought out a fairly good, reliable estimate, and the EPINA project has given us a robust estimate. Wanted to improve awareness of epilepsy and non-convulsive seizures and reduce stigma. I'm sure for many of us, we are quite aware of convulsion as a form of epilepsy or seizure. But what happens if it's not a convulsion? And there are many people that can get non-convulsive type of seizures. What are they, and how do we identify those types of seizures as well? And non-specialist healthcare workers training in the MHGAP guidelines to help pick up epilepsy at the primary care level. For Albert, myself, and our fellow neurologists, diagnosing epilepsy in our clinics wasn't such a problem. But for what happens to those cases that were being seen in the regions and the rural settings? So we needed to get to the bottom of that as well. And then a very novel part of this study was the oral histories. The oral histories has brought up a lot of things that we took for granted. I think at the beginning of the project, I used to discuss with one of our collaborators from Oxford, Sloan Mahone, that this part is a very interesting bit, but it is something that is lost completely on my mind, and it will be interesting to see what comes out of it. And I must say that one of our PhD students, Sabina, did a good job on that one, and the outcome of the oral history things is quite interesting. And you might see some in the workshops that will happen later on today. A lot of things were done, and we cannot enter any district in this country without doing sensitization meetings and getting the real people on the ground, and all these stakeholder things had to be done. And it was in the midst of COVID, so you can see myself and Albert sitting down there wearing those big masks, trying to get this project out there. And I must say that some of the lessons that this project has brought to us is the working or doing research during a pandemic. And I think it is a monumental lesson for all of us for that project. And then we did all these MHGAP trainings. I think we trained not less than 200 or so people within the two districts who are at various level of prescribing. I think in the Ghana Health Service, we call them prescribers, who manage all sorts of cases of epilepsy. And the outcome of this was that there was an improved visitation by patients to these facilities that the staffs were working at. And then we did this by training trainers, because Albert and myself couldn't go through all the places. So we trained a number of doctors to train the prescribers within these regions and areas. And this is one of the program. And then we kept on training the primary healthcare providers at the minimum level how to identify epilepsy, and the minimum medication or the least medication, cheapest medication that can be given to patients at that level so they don't worry themselves. And we even came out to identify that all the main drugs that are needed to treat epilepsy are on the national health insurance. And so in one of the districts, we were able to get like 56 or so, I remember the number, patients living with epilepsy to be registered on an NHIA to get access to medicines. So I think this will come up in the workshop as we move on. And then the prevalence program study, which was a very intensive study. We did a mixed method approach to gather data within the DHSS site. And we build capacity, like Charles said. We have 2 PhD students who are at the final stages of their program. They are at the final stages. And the 2 theses that have come out of this is epilepsy in the Shai, Sudoku, and Ningo Prampram district of Greater Accra region, prevalence and risk factors, and treatment gap. Treatment gap is a very important thing with regards to epilepsy. The number of people that have epilepsy and the number of people that actually receive treatment, and the exploration of epilepsy care pathways. And this has to do with the oral histories, and it's a very interesting outcome with regards to epilepsy. I talk a lot, so I'll just chip in here that it was this thesis that came out of the fact that the carers of people living with epilepsy are equally stigmatized like persons living with epilepsy, not just the person, but even the carers. And you might hear a few from persons living with epilepsy and their carers in this meeting. Every research project should have some publications, and two of them have already been accepted and available for those of us that like to read. You can read about epilepsy within the sub-region. And these four have been reviewed and are at various levels of being accepted for publication. And then these five are under development. So you can see that there's an improved epilepsy management in the primary care from what we did through the trainings. We have a community level model development, and there's a potential for nationwide scale up. We will continue training and sensitization, and there is now a very huge cohort of epilepsy patients living within the DHSS site of the Ningo Prampram and Shao Sudoku district, which forms a very good base for future epilepsy research within the country through the EPINA project. And the data gathered from Ghana and all the other countries helped in the app development that Charles mentioned. And once we're able to get it deployed, I'm sure many even practitioners at the teaching hospital level may be interested in its use. Thank you very much. And these are the great partners, not forgetting the Kolebu Teaching Hospital. Thank you all.
Oh, please, a round of applause. Like Prof said, he can talk. So let the applause be as loud as he talks. Thank you. Thank you very much. So now that we've brought it home and we understand what has been done in Ghana, we would like to talk a bit about the condition that we are all here for on epilepsy, and who to do it better than a professor of epilepsy who has dedicated most of his life to doing research on this subject. So please, let's welcome Professor Arjun Sen, who is going to give us a brief talk on epilepsy. Please welcome him as he comes.
Okay, thank you very much, Daniel. So as Patrick said, we've been friends for a very long time, and sometimes you do things for your friends that you would never ever do for other people. So this presentation was put together whilst Daniel was introducing the meeting. So it's come a little bit out of the blue. Sorry, Charles, it's unexpected, but I'll go through it quite quickly. So what are we really here to do? What we're really here to do is to build a more equitable world through increasing equity in healthcare. And the world is very inequitable. So this is a photo from South Africa, and you can see on one side there are swimming pools and beautiful houses, and on the other side it can be very difficult. And this inequity plays out around the world. This is in Durban, which is where my wife's from. This is in the Philippines. This is in Mumbai, and inequity is everywhere. This is also, though, inequity in America. So you can see very fancy flats on one side and a dilapidated building on the other side of the street. But what we're really trying to do is solve that inequity. And it's not necessarily what you think. So this is work that we did during the COVID-19 pandemic, and it was very interesting. I was just saying to Professor Cross, it's unusual to see us all in masks on those old photos, well, photos from only 2 or 3 years ago. So in the COVID-19 pandemic, we did a survey looking at people with epilepsy and the impact of the pandemic on their epilepsy care around the world. And one of the reviewers asked us to do this disaggregation. So to look at people with epilepsy in high-income countries versus non-high-income countries. And as you can see, if you had been infected with COVID-19, well, actually the rates were very similar across the regions. And this is looking at non-minority. So if you're in the non-minority, i.e. you're the indigenous population, or you're a minority in that country. So COVID-19 affected everybody. But if you had difficulty getting help for your epilepsy during the pandemic, if you lived in a high-income country and you were from a minority, so you're from a high-income country, you're from a minority, it was more difficult to get access to that care, whereas actually in non-high-income countries, it wasn't. So actually things were more equitable in places like Ghana, Tanzania, Kenya than they were in countries such as the US, the UK, Western Europe. So, and that also applied across measures affecting health. So there's a lot we can learn bidirectionally. The WHO put out this report at the end of 2025, looking at major neurological disorders, and you can see that epilepsy features very strongly across age groups. It is a major comorbidity. It's major morbidity in neurological illness, and neurological illness also associates with enormous burden. But there are many challenges and many opportunities. So most people with mind-brain disorders live in resource-limited settings. There are large treatment gaps, education gaps, policy, research and funding gaps, diagnostic gaps. But also in high-income countries, the conditions can affect people from lower socioeconomic groups disproportionately. But it's these gaps that we're really here to try and tackle over the next 2 days. And hopefully we'll be able to tackle all of these gaps, including the policy gaps as well. But what we're really looking for always, so this is one of my favorite slides. This is Usain Bolt, Beijing 2008 Olympics. And what we're really looking for is equity of opportunity. So does anyone know, people except the people who've seen this slide before, why I've shown this slide? Anyone know the Usain Bolt story for Beijing? So Bolt was actually a 200-meter specialist. So he didn't run the 100 meters, and he had to persuade his coach to allow him to run the 100 meters. And then obviously he won the 100 meters by a long way, became a global superstar, and the rest is history. And we're all very grateful to Usain, because obviously we're on first name terms, for doing this, because it enables this photograph to show that you need equity of opportunity in order to ensure full equity. So if we're going to do that, we can't be like this. So Helen earlier was talking about puffins. So here's a photo of a puffin. And we saw the toucan earlier as well. We can't just look downwards. We have to do something like this and actually conquer the waves. But we can't do that individually. We have to do it together. And so we have to, oh, the slide seems to have stuck there. Maybe I've taken Usain Bolt's name in vain, and that's why that's happened. So could we just move the slide on? Sorry. Oh, okay, thanks. So we can think big, but we have to start small, but we have to start, which is exactly what Professor Newton mentioned. So this project, EPINA, started 2019 sort of officially, but it had been going a long time before then, and it's really now sort of accelerated and needs to definitely continue. But we can't do that individually. It very much has to be done together. So I think the reason Patrick asked me to mention something is that to try and help us do that together, we launched the Centre for Global Epilepsy in Oxford. So Professor Newton, Professor Sander, Professor Cross, all are very, very actively involved in this, as are the Ghanaian team. And this is the strategy for the Centre for Global Epilepsy. This is the website. So if you're keen to register on the researcher directory, do have a look at the website and think about joining the researcher directory. And these are the countries that the centre now works in. You can see Ghana represented there, and this is growing all of the time. Don't worry that this isn't the centre. You know, we didn't build this in 18 months. This is the college at Wolfson where the centre is hosted, and you can see there some of our objectives. But the main thing is that we want to create this ecosystem where research, clinical expertise, and advocacy intersect. And that, again, is the purpose of these 2 days, to try and really bring that together and make meaningful change. We have a visiting scholars program, and these are some of the scholars that have visited. Daniel from Kenya, and Nwabisa from South Africa, and there are plans for Frederick from Kenya to visit soon. And we now have money to host visiting fellows, so there will be several visiting fellows visiting over the next couple of years. These are the partners who are crucial to the endeavour, many of whom are showcased on that pop-up banner there as well. But the critical thing is, Usain Bolt's achievement can seem mind-bending. Surely no one can do that, right? But actually, you can do this on the New York Times. So if you go to the New York Times, you can all check it later on. You can do a test as to whether you can beat Usain Bolt out of the blocks. And actually you can, right? It's only a test of reaction time, and you may have to practice a little bit, but you can do it. So we can actually achieve the kind of things that we're looking for. I always try and put Taylor Swift quotes into presentations. So here's one, this is one I use most. So this is for all of you Swift fans out there, Anti-Hero in Midnights. I should not be left to my own devices. They come with prices and vices. I end up in crisis, tale as old as time. And of course, what she really meant by that is no one can do this alone. You have to do it together. You have to involve early career researchers as much as you need to involve senior career researchers, but then you can really make a difference. And so if we're going to make that difference, you can take the building blocks that we have and really build that better, equitable world. So with that, we really need to get started. And I hope that was okay for a presentation with 7 minutes notice. Okay, thank you very much.
That was perfect for 7 minutes. Thank you very much. Please, another round of applause for Professor Sen. We are fortunately graced by the presence of the Pro-VC for Research, Innovation and Development of the University of Ghana, Professor Felix Ankoma Asante, who is here. So we acknowledge Prof. Prof, welcome, and thank you very much. Thank you very much. So now that we've talked about epilepsy and the centers and what is happening in Ghana, we would also want to actually hear from people who have epilepsy and people who take care of those with epilepsy. So we have a 5-minute remark from someone who actually lives with somebody with epilepsy, takes care of the person and the burdens that he or the family actually goes through. So please, with a round of applause, let's welcome Thomas Labi, who is a caregiver for someone with epilepsy, just to share his brief remarks. Thank you.
Good morning, ladies and gentlemen. This feels like home. I want to do freestyle. It's awesome having to know that there are people who are ready to help people who are living with the condition. And like it was explained, I'm not going to boldly say I don't have epilepsy. So it looks like people who have epilepsy, they are less of us. But I'm boldly going to say that I'm a carer. And I've been glad to be. In fact, I got to know this condition in 2006. 2006. So I got married to one in 2007. And I can tell you from the beginning, it was very, very scary. I remember before I saw the condition, I was then in JSS. My seeing it again was when I thought that I found someone I want to marry. But I didn't know the person has the condition. So I got to know the person has it 2 years before we got married. Okay, so it happened. Very, very scary and all those things. But I don't know. Sometimes this question my mother hasn't been able to answer. When she was pregnant for me, what she ate. because the things I saw were supposed to scare me. But that was when I really want to go more and find out what it is. It was very scary the first day I saw it, and I was like, where? This one. And then I had a lot of people who also saw it after some months. And like within a year, it happened even at church. And there were a whole lot of advice I got from people. Like, no, this kind of condition. So they will tell you something like they can't give birth. They can't do this. They can be a liability. A whole lot of things that will put you off. But you see, because I was determined that I was going to do it, I want to show them the difference between Ghana Busli and then the Busli that we know. So I was not backing up. And I went ahead and did all that's supposed to be done. I got married and I was so proud that I did it. You know, if nobody's proud of me, I'm proud of myself. And that is where the challenges started facing up. So then people will tell you, okay, this is what we told you. This is what we saw. And there's this saying that what an adult can lie down seeing, as a child, you can climb the ladder, you will not see. And so there were a whole lot of flying adages and all that just to make you feel you made the wrong choice. You took a wrong step. You didn't listen to advice. But I was also bent on proving them wrong, because I know that everyone has a condition. Everyone needs to be cared for. If you don't have epilepsy, you have something else that you might not even know. So what is the big deal here? And that was where I met Professor Palu and then Professor Ajay. And seriously, I want us to put our hands together for this. They have all the patience you can talk about. Sometimes our interaction with them looks like people we've known for a very long time. I remember when I take my wife for her clinic, and sometimes we talk as far as going to our sex life. When was the last time you had sex? And then I said, hey, for here, you know, these are things you don't want to talk about in the open. But they ask all those questions. And I went back and I sat and I realized the reason they were asking all those things because they want to give you the best care. And that is why I told people who are living with epilepsy that have come in contact with that, you only get better help if you give the doctor the right information. Don't heed any information from the doctor. Give them everything that they ask you that they need to know, and they are going to get help for you. So it continued from there, and that is where my search for epilepsy, my desire to be an advocate started from. And I remember when Dr. Palu gave me a pamphlet, and behind the pamphlet is written www.epilepsy.com. So that is where my learning started from. Things that I don't understand, I'll either ask Prof. Palu, ask Prof. Ajay. Sometimes I worry Dr. Soti because I want to understand, so I can be able to give people better information. And one thing that amazes me was the fact that I thought it was only one case I'm dealing with or one person I'm dealing with. But then I realized that we have about 1% of our population, which is 280,000 at that time, living with a condition in this country I live in. And that was where I realized that the burden is very, very huge. So I started doing programs, going out on my own, because I feel that this is the best I can do to help my home and to help those that are close to me. And today I stand here very, very proud of this experience. That through these programs and working with the doctors, I've been able to help many people. I cannot quantify, but many people to understand that the fact that you have epilepsy doesn't make you less of a human being. And I remember my first program on GTV was with Professor Apalu and Professor Ajay at GTV. And after the program, the bashing I received from people who were watching the program, someone was like, why would you come on national TV and come and talk about these things? We don't talk about it. No. But all these things were learning moments for me. So I could teach others and help them to understand that if you have epilepsy, it is not a death warrant. When you are diagnosed, and everybody actually, anybody who knows about epilepsy, you know that anybody can be diagnosed with epilepsy at any time in your life. It can happen in your younger age, in your middle age, or in your old age. You can get to have these challenges. So why would you want to stigmatize somebody who is living with a condition? Because I remember when my wife had this condition, she was just 6 years when she had a condition, and there were a whole lot of things. And you know one funny thing, that you want to look out for. And even if you meet people who are living with the condition, you just want to help them. The moment it happens, the superstition aspect takes the center stage. So everybody will tell you that let's go. They will take you to all sort of prayer camps. And that is what my wife experienced. But you see, in my territory, the story must change. The story must change. Because I just realized with my interaction with some of these pastors, as someone living with the condition, you have to take your medications. Now, how do you take your medications when you are not eating? And you go and you are asked to fast. He said, you have to fast to clear this thing out. I said, see your face. You are joking. And I just realized that they themselves, they are ignorant of what we're talking about. So we've had series of programs with the doctors, with the medical professionals, even including Dr. Chawi, trying to help and bringing faith practitioners and then faith healers, as they call themselves, to come and understand. And there was a time we had one program where one of the faith healers came with the name of Dr. Apalu, and it was very funny. And the things he stood on the podium and said, you will laugh. But they don't have basis. But this is what they believe. You can't blame them. So it was our responsibility to teach them and help them understand. My journey in this path has been more encouraging and more fulfilling. Sometimes I say that I don't know what tomorrow holds. But if I should die tomorrow, I'm proud that at least I was able to help one person to feel more of him or herself. And that is what I believe we are. That is the reason we are all here, because we want to help each and everyone to stand and know that the fact that you have the condition is not a death warrant. Epilepsy is treatable. Sometimes I tell people I don't want to be overzealous by saying that epilepsy is treatable. So I say saying epilepsy is curable, but I want to use the word epilepsy is treatable. But in the midst of the treatment, we find cure. Because if I'm having epilepsy every day, and for 1 month I'm not having epilepsy, 1 year, 2 years, I'm taking my medication all right. What do I want to call it? And that is what I believe all of us can do. And there's one thing I also realize and I find, and I tell people who are living with the condition that, you know one thing, I don't want to tell you everything is going to be smooth. So when you go and it is not smooth, then you go, but the gentleman said it was going to smooth, and it wasn't so. When you have epilepsy, just be ready for the obvious. But my duty is to make you strong. My duty is to encourage you. But just make sure, say, you are also ready to be encouraged so you can beat everything that comes. Because I just realized that one biggest thing we face here in Ghana, but it has reduced. Because I remember in 2011 at GTV, and now there has been a lot of changes. Doctors, health, and medical practitioners have done a lot to make sure that this is going to happen. And I said to myself, Prof. Apalu, Prof. Ajay, Dr. Chawefeli, and the rest of the doctors that are working on this, they can't have all the time to go to people, because you can just imagine doctor to patient ratio, even in Kolebu and other health facilities. So then I take it upon myself to make sure I'm going to encourage and advocate wherever I find myself, so people will understand. Because I just realized that misunderstanding and lack of knowledge to this condition is making the condition itself difficult. Else, this shouldn't be a problem for me. It shouldn't be a problem for anybody. And that is why I said that the stigma about epilepsy is more difficult. Dealing with epilepsy as a whole, the stigma that it comes with it is even more difficult than the condition itself. Because you see somebody having the condition, he has a condition, he fell or whatever it is, and then you want to try and save them, protect them from hurting themselves. But after that, those standing and watching it from that day, when they see the person coming, they will use another lane. They will not use the same lane they don't want to sit at the same place the person sat and stood up. They don't even want to drink from the same cup the person drank from. And that alone gives that person serious mind-boggling issues, which can even trigger the condition each time. So that makes it more difficult. And I want to use this opportunity. I know we are already doing it, but I just want to employ us. Let's get our seeds on. Let's give the information that is needed. Let's give the information that is needed. So we'll be able to help people to battle with this condition. Because I bet you, even if you're able to save one with the knowledge, the Lord is going to bless us. And please don't ever move and think that epilepsy is spiritual. No. Even if it is, you see that God that is there, He has given us wisdom. So when you pray for God to give you wisdom to deal with the physical. Don't allow anyone to deceive you by saying epilepsy is spiritual, so you need to go to church, you need to do some akwanchere, and they will chop your money left and right. Meanwhile, you need the money to get medications, so you are going to be. And I can thank all the stakeholders who have made medication more accessible. Because I remember those times I have to pay for my wife's medication, and that was a huge burden financially. Until national health came, even sometimes you go and there are a whole lot of stories, but you still get something to protect the program. And you see, I remember when someone said that people with epilepsy cannot give birth. Okay, so I wanted to find out, is it true they can't give birth? I forget my name. Many people hear Thomas, they say you are doubting. That is not it. I want to see. I want to prove myself. So when I stand and speak, I speak with passion. So I remember we got married. Not long I had my first child. I actually lost my first child. Boom. And it started. People made me feel horrible. You see, so the one that doesn't want to talk will do like this. And you know what this means? I told you. We told you. You know, it was continuing. And when it happened, I said to myself, the story must change. It can't continue. I can't lose. After I lost my first child, 3 months later, somehow, I know God was involved, but I was more involved. 3 months later, we had a first embryo started growing. And then I gave birth to my first daughter. It was like I've gone to heaven and back. Because I now have evidence to teach them, to tell them that people living with the condition can give birth. They can live a normal life like any other person until they have a seizure that their life is interrupted a bit. After seizure, life continues. And that is what it's supposed to be. And I named her after Dr. Apalu. But she's a girl, so we name her we name her Pearl anyway. But that girl was dedicated after Dr. Apalu. And then going forward, I am one guy that loves to give birth to girls. I'm not really fancy guys. No. I don't really like boys. I want girls. So my first daughter I lost was a girl. Then Pearl came, Pearl girl. And then the next one, because I realized that the equation has to be complete. It has to be completed with the girls. So then I got another girl again. I gave birth to another girl again. And I named her Albertina. And Albertina is a female version of Albert. So when I say that, you know what I'm talking about? So I'm talking about Professor Apalu. Professor Apalu is Albert Apalu. And Professor Apalu and Professor Ajay, they were there, even before we met Dr. Achawi, they were the angels that God sent to us. And the other day I was promising that you should not worry. I'm going to give birth to a boy for his sake. So I'll name him Patrick. So yes, we've proven to people that yes, they can give birth and everything can be normal. Anybody living with epilepsy is as normal as any other person you can think about. And I believe that when we put our heads together, we're going to push the wheel along and we're going to make every person living with whatever condition, especially epilepsy, will be great. Thank you very much. Thank you.
Thank you, Thomas. I thought he was going to say it's going to be a girl so that we call her Patricia. Thank you very much, Thomas. There is actually more to Thomas's story that I would want you all to wait in the next session. You're going to hear a lot about Thomas. He's not the only one who's here. We also have other people living with the condition. We actually have persons living with the condition and other caregivers who would also share more information for us. So please, we have more in store for you. Just relax. I would like to acknowledge a few people as well who are here. Our partners, WHO is here, duly represented. They are here. Please give us a wave. Thank you very much. Thank you for coming. We have the Ghana Health Service, duly represented by Dr. Lawrence Ofori Boadu, who is the Director, Institutional Care Division. Doc is here. Thank you. Thank you for coming. We also have Dr. Alexander Ajay, the Medical Superintendent of Shai Osu District, Osudoku District Hospital. Doc is here. Thank you. And then the immediate past director for the Dodua Health Research Center, Dr. John Williams. Dr. John Williams is here. Doc, thank you. Thank you also for coming. We would also hear from a few of other people, but before we do, we have a presentation on the IGAP, the reason why we are here. We have a presentation on IGAP. And we would first of all hear from the global IGAP partners. So we will have a presentation by Dr. Chido. The other names, I would leave it to her to present herself. It's a very unique name, and she is the only one who can pronounce it very well. So Dr. Chido is a consultant psychiatric and a public mental health specialist, and she's currently the mental health regional advisor at the WHO regional office for Africa, supporting African countries to strengthen mental health systems. She has previously served as the Deputy Director for Mental Health Services in the Ministry of Health and Child Care in Zimbabwe. She's also served as a Senior Associate for Mental Health and HIV integration with the Clinton Health Access Initiative. So she is keen advocate for mental health, actively promoting greater awareness about mental health and well-being at individual, family, and community and organizational level. Please, ladies and gentlemen, we are going to hear from Dr. Chido online. She's ready. Please, with a welcome applause, let's welcome Dr. Chido. Yes.
migraine, that issues that are there that affect neurological conditions as well. And if you can access the framework in the QR code there, and some of this data is coming from the Mental Health Atlas as well. So we know that 29 countries have mental health policies. Sometimes these include some of the neurological conditions, and 20 of the countries have includes neurological conditions. And for neurology, standalone budgets, only 7 countries have that. In terms of service expansion, what we indicated with primary care training, but comprehensive primary care integration, only 7 countries of the 47 countries we are following are doing this in a comprehensive, effective manner. What is comprehensive primary care integration? It's we use 5 criteria to try and grade if a country is integrating mental health in a comprehensive manner. One is their guidelines to indicate how primary care mental health should be integrated into primary care, and this often includes neurological and substance use conditions. So a guidance document like MHGAP, if it has been adapted in the country and it's guiding this integration process. Then is there training for primary healthcare workers in managing mental, neurological, and substance use conditions? And then is there support, supervision, and mentorship through the available specialists? So the primary care practitioners need that support support, need the supervision, need the mentorship so that we maintain quality as we task share. And then the fourth criteria is the availability of psychotropic medications, of anti-seizure medications at primary care when they're needed. And then finally, the availability of psychosocial interventions. So the medications need to go along with the adequate skills in the primary healthcare colleagues to be able to provide some psychosocial support and care. And countries that score 4 out of 5 or 5 out of 5, there are only 7 in the region at the moment, and we're hoping that this will be something that can be improved in the coming years. And we're still struggling in terms of specialist health workers for both neurology and psychiatry, which is where epilepsy is often managed in the different countries. I've also mentioned mental health psychosocial support because often there's disruption of care where there are disasters and there's interruption of services. And 16 countries, actually, it's improved from 11 to 16. 16 countries actually have a mental health and psychosocial support component of their national disaster preparedness plans. And this helps to protect people living with neurological conditions, mental health conditions during times of disaster so that there's no interruption of services. Including medications, anti-seizure medications, psychotropic medications in the emergency medication toolkits. Again, suicide is something that is very, very worrying in the region. 11.5. The regional suicide rate is 11.5 per 100,000 population. I bring this up because it affects conditions throughout. So throughout the mental health conditions, the neurological conditions, substance use conditions, often there's a higher rate of suicide, and it's something that we're trying to also grapple with. Only 6 countries have actually developed national multi-sectoral suicide prevention plans. Lastly, the data, 24 of the countries are reporting on mental health data, but only 15 of the countries are reporting on neurological conditions. So bringing up the IGAP, so I believe I'm preaching to the converted, but we will give an overview of this as well. This is a global action plan to address epilepsy and other neurological conditions with 5 objectives and 10 global targets. And this is what is shaping a lot of the work within the region and globally around neurological conditions. What are the 5 objectives? To raise policy prioritization. Really, these are conditions that have historically been neglected, have not been prioritized, whether it's in policies, in plans, and part of the IGAP is to try and raise that the prioritization of epilepsy, and also to strengthen governance. So through the policies, through the legislation, is to strengthen the governance. Then there's a need to then provide effective, timely, and responsive diagnosis and treatment and care. As we say, the treatment gap is quite large, and this is a big part of what needs to happen in order to improve care. Then implementation of strategies for promotion, for brain health and prevention of neurological conditions where possible is also one of the key objectives of the plan. And to foster research, as was being done through EPINA and the various research studies that have been done at PhD level, at master's level, to really foster research and innovation, but also to strengthen the routine data collection systems so that we can capture that surveillance data. Last but not least, to strengthen the public health approach to epilepsy. So to look at this as a public health priority and to be able to then strengthen the health systems that will then ensure that we reduce the treatment gap. So what are the targets? These are the global targets, but we are part of those countries and we're working towards this in the African region as well. The first set of priorities has to do with adaptation, updating of existing policies to include neurological conditions. And like I said, we're trying to move beyond. It's not just epilepsy, but also the other neurological conditions as well, to have them included in existing national policies, and if there are some countries that may have some standalone policies. And then for countries to have at least one functional awareness campaign and advocacy program. As you can see, there's the great need to combat issues around stigma, misinformation, myths, and this is greatly done through functional awareness campaigns and working with people with lived experience in this. Then the second set of targets has to do with financing and access to medicines and technologies for countries to include neurological conditions in the universal healthcare benefits packages, and also for provision of essential medicines to manage neurological conditions in primary care. Third set of targets has to do with the intersectoral nature of epilepsy and other neurological conditions, that it's beyond the healthcare system alone. It's across the lifespan, so it's brain health across the lifespan, but it also then engages other sectors that need to be included in this discussion as well, in order to be able to move the dial on not only the treatment gap, but quality of care and quality of life for people living with epilepsy and other neurological conditions. And then, of course, for us to then make sure that we are working in tandem with the other projects that are going on, the other global action plans, the other regional plans, that we are all working towards the same goal. So the Defeating Meningitis plan is a big part of this as well in terms of prevention. Every newborn plan as well is also very critical in terms of prevention as well. And then the NCD gap as well. The fourth set of targets has to do with data and research, encouraging countries to have routine data collection of a core set of neurological indicators, which is something that we are still working at, and to have a report of some sort happening every 3 years towards neurological conditions. And then the research output to improve that by 2031. The fifth set of targets has to do with service coverage, but legislation as well. So we need to strengthen or increase service coverage by 50%, which will then improve access to care for the people who need it. And then the legislation to protect and to promote the rights of people with epilepsy and other neurological conditions. There are a few things that WHO has been doing to support this. Policy dialogues like today, leadership and advocacy, encouraging this, investment cases as well. There's some technical products that I'm sure you are well aware of. The implementation toolkit for the IGAP, the policy brief on brain health across the lifespan, and also the guidance on improving access to neurological medicines. Monitoring through the IGAP survey, and this is something that will continue to happen periodically, and the global status report for neurological conditions as well. And then supporting countries to implement their frameworks. There are a number of countries that we're working with that I will spotlight just now, including Ghana. And then engagement of people with lived experience is a key part of the way we work. So these are the technical products, a wide range of them. I think many of them you've been aware of across the years, and very useful. And if you need access to them or you're struggling to access them, please do get in touch with the country office or with myself, and we'll make sure that you have access to these. And just highlighting the improving access to medicines guidance, which you can access using that QR code, which looks at the significant barriers that are there for access to medicines for neurological conditions, and how we can then assess, support countries in assessing where these bottlenecks are for the individual countries and how to overcome them. But this is work that has already started happening in Ghana. So we can move on to some of the examples from countries that are working on this. I'll start with Tanzania, one of the early adopters together with Ghana. They had their first implementation stakeholder meeting back in 2023, and they conducted an assessment on availability, affordability of medications, and then they had a subsequent meeting, again stakeholder meeting, to plan on work being done. They have then had the EPINA meeting prior to this one a few weeks ago, and they managed to then reflect on what has happened, the many gains that have happened since 2023. And quite a lot has happened. I've just summarized a few things there in terms of procurement of medications. Quite a lot of changes have happened, and inclusion of neurological conditions in the insurance fund package, which is critical in terms of funding. Kenya has also done significant work. They did a consultative workshop in 2024, and they will also be doing an EPINA workshop in the next few weeks. Then we then moved to Sierra Leone. Sierra Leone, has been work in terms of doing a stakeholders meeting in October of 2024. And then a technical working group was then set up to coordinate work for IGAP implementation. They've then integrated epilepsy into the mental health and NCD strategies, but also have been working with the education sector to ensure that children with epilepsy continue to go to school. Then we are working on a project in 3 pilot countries on improving access to neurological medicines, which is now expanded to psychotropic medications for mental health as well, working with Cote d'Ivoire, Ethiopia, and Zambia. So they have been working on country health system assessments. I think all of them are pretty much done with that. And 2 of the countries have also done, Cote d'Ivoire and Ethiopia have also completed their affordability and availability surveys. Zambia is working on this one. There are plans for capacity building of primary healthcare workers to improve access to care, and updating of national treatment guidelines and the essential medicines list, and then work to also improve supply chains and monitoring frameworks. Back in 2024, we did a regional webinar. This was really as a result of poor uptake of the IGAP survey. So we did a meeting to try and ramp up support for this. And we had invited the IGAP survey designated focal persons from the different countries. But we also had mental health focal persons and organizations working with people with epilepsy, neurologists, pediatricians, psychologists, psychiatrists attending the meeting as well. It was really to raise awareness about epilepsy and other neurological conditions and the IGAP and the importance of the IGAP survey. And we worked together with ILAE and Band Foundation and the Clinton Health Access Initiative. So from this, there was some excitement around that, which then led to us getting a little bit of funding to do some in-person meetings, the first of which was held in Johannesburg in October. And this was to accelerate IGAP implementation in Southern Africa. Some funding had been given to South Africa for implementation of the IGAP. So South Africa had adapted the IGAP, and they actually call it the SINAP. It's now actually being tabled before cabinet in South Africa. So they were being supported in terms of how to finalize that process and roll it out. And we saw this as an opportunity for inter-country learning in countries that were not receiving any support. So Botswana, Eswatini, Lesotho, and Namibia then joined South Africa in an in-person meeting, and each country had done a landscape analysis of neurological conditions in their countries prior to the meeting. And then during the meeting, they presented on this, and there was a lot of discussions and group discussions and inter-country learning about what is happening in the different countries, and quite a lot of, healthy camaraderie and competition about what can be done, even if the resources are not many. And we then did a follow-up meeting online in December. All the countries came and they reported on work that they'd done in the 2 months, in between, and that was quite encouraging. And their plans, they also shared with us their plans for 2026. So to continue to maintain the momentum, we've also then formed a community of practice that will be meeting every quarter with this group of countries. And then moving from there, the next one will be held in Ethiopia. It will be for East Africa in June of 2026. And this will include Kenya, Tanzania, and Ethiopia, which are countries that have been doing some IGAP work, but also South Sudan and Uganda, where we've not had much attraction as yet, to again encourage this inter-country learning, that even with a small catalytic fund, we can then encourage many more countries to join in. And we're hoping that the community of practice will then extend to 10 countries. And hopefully the next one, if we get the funding, will be in West Africa. So yes, we get to Ghana. I won't say much because that's what we're here to do and hear about more. And Ghana was the first of the African countries to actually actually adopt the IGAP and start implementation. So it's quite exciting, and we would love to hear what has happened since then and the changes that have been occurring. Last slide. Key challenges, lessons, opportunities. So there is a need for prioritization of epilepsy and other neurological conditions in national agendas. Really it differs in many countries where epilepsy lies, but there is a need to find a definitive home because sometimes it falls through the cracks. Is it with NCDs? Is it with mental health? Where does it lie? And that is one of the challenges that we see sometimes. Then we have issues around stigma, meaningful, and there's a need. The lesson learned here is the need for meaningful engagement. Can you still? Oh, okay. I'm almost done. This is the last slide. Meaningful engagement of people with lived experience. This really is the best way to fight stigma. Then there's a need for coordinating mechanisms. Many times there are several organizations that are working in this space, and there's a need for us to work together for greater use of the available resources. But there is a need for predictable financing through dedicated budget lines and domestic financing so that the program has funding that is dedicated for it, whether it be included in an NCD funding or included in the mental health funding, as long as there's actually dedicated a budget line or sub-budget line, this really helps. The need for integration of healthcare services at primary care to improve access, but with the necessary support, supervision, and mentorship frameworks. And then, of course, access to medicine is key. We're still lagging behind in many of the countries in availability of medicines for neurological conditions. And the need for robust monitoring and evaluation and that routine data collection is also critical. So I will stop here and hand over back to the chair. Thank you.
Thank you, Dr. Chido. Very good presentation here. So we needed to set the ball rolling on that since this is our main agenda for this meeting. We've had enough information from Dr. Chido. We are grateful. After this session, we would hear what is happening in Ghana on IGAP, and the WHO representation in Ghana would do that for us. However, I understand we have some Ministry of Health participation here. If you are here from Ministry of Health, so that we can acknowledge you very well. Is anybody here from the Ministry of Health? Oh, thank you very much, sir. Welcome. We would like to hear from the Ghana Health Service, which is our key partner. They will give us a brief remark on access to medicines and other issues related to neurological disorders. And to do that for us is Dr. Lawrence Oforibodu, who is the Director, Institutional Care Division. Please, a round of applause as he comes.
I think it's still morning, so good morning to you all. I would like to start on the existing protocols. I'm here on behalf of the Director General of Ghana Health Service, who is a neurosurgeon, and this workshop is so dear to him because neurologists work with neurosurgeons, and they are partners in the field of supporting people with conditions that relates to the brain, the spine, and every aspect of our reflexes. So he is on the bill to be part of this very important meeting, and he's asked me to step in, but I hope that you pass through because he has an urgent call that has taken him out. And so as a director responsible for clinical service of the Ghana Health Service, where mental health and psychosocial support is critical in this area, where primary health care is key to us. And now one of the most flagship programs of the president on Mahama Care, that with chronic condition, non-communicable diseases, is also one of the areas we are actually taking up. It is proper that we have to be here to add our voices in the form of advocacy and also to reassure the gathering here and the community and Ghana at large that the service is doing everything possible to do the best of the primary health care, early detection, advocacy, community education, and setting up the system that can pick people or clients who come with us with neurological disorder conditions, including and not limited to only epilepsy, but other conditions that affect the population. In this Intersectoral Global Action Plan, Ghana Health Service has been part of it in strengthening public health approach to epilepsy in Ghana. I remember not long ago, we were part of the advocacy team that worked on including some basic 4 conditions of mental health into the National Health Insurance Scheme. And we feel that that advocacy was good because even though it wasn't specifically for epilepsy, anxiety disorders were part, bipolar disorders was also part, schizophrenia, and also depression. And so we have made some strides in bringing closely to people living with epilepsy and other disorders into access. To us in Ghana Health Service, it is not just about access to physical infrastructure, but no financial barriers, access to medication, and access to quality of care is our backbone. We cannot have quality of care without medications, access to medication. We cannot have quality of care without having access to specialists who take care of our clients. Ghana Health Service for some 5 years now have been very proactive in training family physicians, who we call them primary physicians, who will be able to support our cadre of general practitioners to pick early, identify early people with neurological conditions, and then also start or initiate the care and refer appropriately. So to us, we have been supporting capacity building in areas of epilepsy. We have been supporting advocacy in areas of epilepsy and neurological condition, and also pushing for access, which is very critical to this gathering. We are not only limiting ourselves to the physical boundaries of our practice walls, but we are also out there in areas of public education. How can we educate the public to be very proactive when we have people who may have conditions or active involvement in epilepsy? The core is to educate the community, not to pour water on people who may have seizures, but to call for help, to restrain them from any injury by cushioning them, and the most importantly, by calming them. To us, this is a primary call. As an emergency physician by practice, I've seen many people run to the emergency room with conditions likely to be or presumed to be epilepsy. But most of the time, when you come closer and you reassess them, you realize that more harm has been done before arriving to the emergency room. So we feel that it's not emergency room or the treatment centers alone that will support, but public education. How is the public minimizing stigma? How is the public seeing to it that we are not tagging anybody with neurological condition as somebody who is not part of the society? I happen to have a research when I was doing my MPhD on chronic conditions and how to cost for the care. I was supervised by one Professor Akins in School of Public Health, household cost of people living with chronic condition. So as an emergency physician, I had experience of a lot of intangible and indirect costs of even managing people who may have chronic conditions. So the care of epilepsy needs everybody. The intangible causes, the depression, the stigma is so huge that many a times we don't see them as a physical cause. The indirect causes, parents not going to work because they have to take their children to school. They have to stay by their children at hospitals. They have to lose job. Even some are divorced because of people living with chronic conditions, including epilepsy. And so we are so much involved in it. And the Director General of Ghana Health Service has expressed his concern that every time you need the service of Ghana Health Service, we're ready to support. We are already in the boat with you. And we are so grateful for inviting us to be part of this meeting. Thank you very much.
Thank you, Dr. Wedu. We are almost at the end of the opening session. And we are grateful again, like I did indicate, to have the Pro-Vice Chancellor of the University of Ghana with us. So he would give us the last remark and open the meeting for us. after which we go for a snack break. First of all, we'll take a group photograph after this, and then we go for a snack break. So please, ladies and gentlemen, let's welcome Professor Felix Akuma Asante.
Thank you very much. I don't have any formal speech, but I'm just going to base my presentation on what I've heard this morning. On behalf of the management of the University of Ghana, I wish to welcome you all to this important meeting, especially for our colleagues and partners who've traveled to Ghana. I can see University of Oxford and UCL, sorry. Thank you very much for taking time off to be part of this meeting. At University of Ghana, we cherish such engagement. I came a little late, but forgive me, too many things this morning. The Vice Chancellor is not in, and I have to step in certain things, but I'm here, that's the important thing. As a university, we have our research priority areas. We have 7 research priority areas, and our approach is to address these research priority areas through a multidisciplinary approach. As I was listening to Thomas, listening to Ghana Health Service, listening to WHO, I asked whether I'm at the right place. I'm a development economist. Okay. And I've always been telling my colleague health practitioners that we will not be able to solve development health challenges if we don't involve social science. We can have the best of the medicines. I mean, the issue of stigma is a social science issue. It's not a medical issue. So I'm hoping that as you have further discussions, some of look at it as a multidisciplinary approach. The health part, yes, we've advanced on it, but how do we move forward? So I'm very, very passionate about that. It's not because I'm a development economist and I'm not a medical person, but I think we've done a lot as a country and we've done a lot globally to help address some of these health challenges, and we need to move our research forward. So as a university, our 7 priority areas, the first is infectious and non-communicable disease, and certainly epilepsy falls directly into that first category. We also have food production and processing as the second. We have climate change as the third. We have the whole area of development policy, monitoring, evaluation as the fourth. We have education and communication as the fifth. The whole area of sociocultural change as the sixth. And then the last one is the fourth industrial revolution, where we look at the use of big data. I mean, we've advanced. If we have big data, some of the issues that we are grappling with, we will understand it more. Okay, so as a university, we try to use a multidisciplinary approach. So for instance, with our 7 priority areas, we expect that our 4 colleges, we have College of Basic and Applied Science, College of Health Sciences, College of Education, and the College of Humanities. We expect that each of them will be able to address the 7 priority areas so that we can make progress. So this stakeholder engagement, I see it as very, very important. And I'm hoping that you have people from the different disciplines to also contribute. Listening to some of the introductory backgrounds, especially from WHO, where we have about 4.4 million of the population with epilepsy. This is a huge number, and I think it's better late than never. It's good that we've identified these issues and we've made it an important topic. And coming to Ghana, about 330,000 of our population. This is about 1/10 of our population. So, meaning that if you walk out, every 10 people that you see, 1 person has one form of epilepsy. And this is very, very important. The director from the Ghana Health Service talked about the indirect costs. At times, the indirect cost is so huge than even the direct costs. And he talked about the issue of stigma. How do we even quantify stigma? And stigma, depending on the individual, right? It can be a very big blow to you, depending on how you can take it. The issue of care, the issue of not going to work. And I'm sure if you go further, even to look at the contribution of uh, uh, people with epilepsy and foregoing their work. When you look at their contribution in terms of GDP, I'm sure we'll all be shocked. So this is an important topic, and I'm hoping that as you deliberate on the issues, also take up our environment. As a developing country, we have challenges with access, and I was shocked with the WHO information on access that even in urban areas we are found wanting. And so you can just imagine what is happening in the rural areas. So I'm hoping that as you have your discussion, you open up, look at our circumstance, the African environment. Let us also learn a lot from our counterparts in Europe. What have you done to also reduce the burden? And I'm sure at the end of the day, Ghana benefits globally, the continent and the whole world also will appreciate the work that we are doing. I wouldn't talk too much because I'll be so passionate about some of these things. So on this note, I formally open the stakeholder engagement. I wish you all the best. I look up to a fruitful discussion, and I'm hoping that as I was invited, I'll also be giving the feedback of the outcome of this meeting. And as a university, whatever we need to do to, at least in our own small way, to project the importance of epilepsy in our environment, we'll certainly do it. So once again, thank you so much for making time for this meeting.
Thank you very much, Professor Felix Ankuma Asante. So now that we have permission from the host to carry on with this event, we'd like to officially bring the opening ceremony to an end. Thank you all for coming. Just a few announcements. There are media teams represented here, both print, online, and then television. So those of you who will be assigned to talk to the media team, please give them a few minutes of your time and they can have a few discussions with you. Thank you. We have snacks on our left side here, but before then we'll take a group picture outside. The camera team tells us it gives us a good picture that way. So please, let's all file out small to the main or outside there and then take the picture, and then we take our snacks and come back for the second session at 11:45. Thank you very much and welcome. Hello? Okay. Hello, everyone, please. Those outside, could you kindly come in? If you're outside, come in. We are about to start the first session of the day. Hello, everyone, come in. Come in, come in, come in, come in. Thank you very much. Thank you. So we move on to the next session of the program. And this session is the IGAP implementation and advocacy. So this is where we are going to discuss and have in-depth discussions in the program. We'll have presentations from the relevant partners, and after that, we have a panel discussion to discuss on the issues that are on with the IGAP and its advocacy. So it's in two parts. One will be on the IGAP implementation. Our partners, that is WHO, the EPINA group, the Ghana Health Service, and possibly the MOH would lead this discussion. And then the second part is going to be on advocacy, and also the partners from the Ghana Neurology Society, the EPINA team, and our of the EPINA team. Please, with a round of applause, let's welcome him as he continues with me.
Okay, so welcome back from the snack break. Just like my co-MC said, this session is on IGAP implementation and advocacy. We will take two presentations for this session, and then we'll move into the panel discussion. So the first presentation, I would like to call upon the focal person, IGAP focal person in Ghana, Dr. Richard Asamoah, to give us his presentation.
Okay. All right, so it's almost afternoon. So good morning, everybody. So this is a general overview of the baseline work on IGAP so far. I must say that it's mostly qualitative data looking at where we are so that we know where we are moving from. My background is mental health, so you would pardon me if I start chipping it in every now and then. So we've talked about the treatment gap already, and doing this data collection process, one of the things that I did come across was that we do have quite a gap. Although it shows about 10% of people with epilepsy getting treatment in Ghana, I think that's actually not a very accurate representation. I'll explain why as we go on. But then most of the discussions on the background of the IGAP program has already been mentioned, so I'll not bore us too much with that. I'd say that from somewhere mid 2024, we started collecting the data, but it was to capture data of 2023. So it was mostly from January to December 2023, looking at what the situation is in terms of neurological diseases or disorders. So not just epilepsy, but across the board. So first, looked at legislation, policy, and funding. And if there were legislation covering people with neurological disorders, and we did find that the main legislations that covered neurological disorders in the country are Disability Act and the Mental Health Act. And for national policies, there were very, very specific disorder policies for neurological disorders, but looking at various national policies, there were some mentions of neurological disorders. In the aging policy, for instance, there are mentions of dementia. In the communicable diseases, we have meningitis, And non-communicable diseases, we have epilepsy and so on. In fact, one of the things that I found interesting, maybe we'll have to follow up on this money, because I actually found that there's actually funding allocated for neurological disorders, actually a whole budget line in 2023. But till now, I'm not too sure if any of us knows how this was used to support neurological disorders. Then we looked at healthcare services. So looking at the population, number of neurologists per 100,000 population, I decided not to do the actual math because it wasn't looking too nice. So you can see that as of 2023, about 16 neurologists across the country. I think it's increased a bit since then, but not by 2. So now there are 18. The neurosurgeons were about 25 at the time. I'm sure there are probably 1 or 2 more. Then we have others like the psychiatrists and psychologists, but you can see that from these numbers that there's a huge gap. There are some specialized services available like outpatient and inpatient neurological services, stroke units, neurointensive and rehabilitation. But most of these were found to be in the urban centers. And so means that there's a huge gap, usually in the rural, especially in the rural setting. Then in terms of training and capacity building, most doctors, nurses, and other cadres of healthcare professionals do receive some neurological training in neurological disorders. In the districts and mostly the primary care setting, the major source of this training is the MHGAP program, which includes neurological disorders such as epilepsy and dementias. In terms of care for support for carers, it's a major challenge that there aren't clear policies, but there are agencies, NGOs, and other organizations that do provide some support, such as the Alzheimer's Ghana and other societies. Then we looked at treatment. So treatment pathways, there are some national guidelines and programs that support treatment and medications. The main challenge is that there are some covered by health insurance, some that are not covered. Then, so quite a number of the support ends up coming from donations. Then people seeking care also have to pay largely out of pocket. And some are either not available or very expensive. So these are major challenges that we noticed in treatment pathways. Then in terms of information systems and research, and here there are major challenges, and going forward we'll have to look at. So the data I obtained were mainly from the DIMS and the LIMS at the time, but you would agree with me that, or know that now LIMS is more or less no more, which means that if you need patient data over the past 5 years on neurological disorders, you have a hard time finding it. And I was just sharing during snack that if I had to do this work now, it would be very challenging being able to get that kind of data. And of course, there are private healthcare systems which may also now pose a challenge getting data on the number of neurological disorders they are seeing. Of course, also the challenge of what you call is it healer shopping. So you could be counting people multiple times because you are jumping from one private to government and so on. So these are some of the challenges that there are with our systems. Then there are also challenges with diagnostic entries. So here, remember I mentioned that although it looks like we have just about 10% receiving treatment, looking at it, the suspicion or the idea is that it is likely that a lot of those who are being treated are probably not being captured in the system. Either the diagnosis is not clear or they are naturally not stating it, so it's not being reported. Because it was strange that some facilities that you'd expect to have larger numbers because you have neurologists and other, or some other facilities where where they are larger, and you've probably worked there and know that they have high flow of cases of neurological disorders. We're reporting very low numbers. Then in terms of research, we are making quite some progress, as in we are making with EPINA, KNUST, University of Ghana, and others are also working, doing quite some good research and on neurological disorders. Then we also looked at community engagement, promotion and prevention. So there's been quite a number of engagements. In fact, when I started doing the collection, I then actually noticed that we've been doing a whole lot that probably is not being noticed. When I started, I was asking from Dr. Jima and others, so I'll call Kumasi, and Kumasi say, oh, we are doing this. I'll call here, it's like, so how come I didn't know about all this? Maybe I was also in my corner somewhere. And that's probably why it's good that we are together now, looking at moving forward. So you can see all of these programs, and these are just a few. If you think about it, there are a whole lot more that are being done in the field of neurology and brain health. Also, in terms of involvement of people with lived experience across the disorders, there are some organizations that are supporting. I mentioned Alzheimer's Ghana. There are various advocacy groups like Ndaso Parkinson's, led by Dr. Vida in Kumasi and a few others going on. And so there's quite some work. Again, there's still a lot more to be done. I'm hoping that we would work on that. So the way forward from here, having summarized where we are, clearly there are still a lot of things that need to be done. So looking at allocated funds for the purpose of neurological disorders, we have to actually find out where the money is going to. And then we also need to, even if it is going, we need to ask for more. I'm sure you agree with me that it's still woefully inadequate for the amount of work that needs to be done. Particularly, I find that a lot of funding for research in neurological disorders in Ghana, either they are getting donors from outside or they are not getting any research done. So it's something that we have to look at, that how do we get the funds allocated locally? And then we need to look at the policies, and so some of them have not been reviewed as far back as to 2017. So some of the information and knowledge there needs to be looked at again. Then also look at having specific policies governing or covering neurological disorders specifically, and then we can link them to those other policies that already exist. Because sometimes, because it is more like an add-on or sometimes even an afterthought, it doesn't really do justice to the kind of work or information that needs to go into it. And then we also look at human resource capacity. If since 2013, so 2023, we've had just about 2 or 3 neurologists joining, then we are nowhere near getting even to a point of saying we have 2 to 100,000. And that is definitely challenging. In the meantime, we'll look at task sharing. And that is one of the things that underpins the MHGAP program, which is a major contributor to the IGAP program, where we train primary care physicians, nurses, and other healthcare professionals to at least identify neurological disorders, start treatment, and then refer where necessary. And also look at extending specialized services to rural areas. Again, this will come up again with capacity building, because if you have only 16 or 17 or 18 neurologists in the whole country, even if you give 1 per region to the 16 regions, they eventually would have to end up in the regional capital. So then your rural areas are still going to struggle. So that's something that we have to look at. And then look at availability and affordability of treatment. It's mentioned that for psychiatric disorders, about 4 of them have been put on the NHIS now. I'm still yet to see the full implementation of that. And even for those that are already on, like epilepsy and so on, to what extent are the drugs and treatments really available? These are things that we need to look at. And then information systems. I think because of my experience with the system when I was trying to get the data, I'm still very passionate about this, that we really need to streamline things. Getting data on neurological disorders in Ghana is very difficult because they exist in silos and the reporting on the data is also very scanty. So you can't really, in fact, I had a hard time looking at splitting it into how many males, how many females, how many young people, and so on. And this was a major reason why we had that challenge. And look at a collaborative approach to information and research. As I mentioned, there's a lot going on. I was amazed at how much work we are doing in the neurological field when I did this work. But again, there's still a need for a more collaborative and coherent approach, and also enhance data collection and availability. I think in our training, we may have to look at, or in the going forward, we have to look at having some sort of standardized approach, particularly for those who are not specialists or not specialist level, to be able to properly enter diagnosis. I think sometimes people are afraid to make a diagnosis of epilepsy. So they would probably say seizure disorder. So if you're looking for epilepsy and you enter epilepsy, you will miss all of those diagnoses. Or they may write probable or suspected or something like that, even when it's clear, to avoid having to probably tag the person. Then looking at involvement and representation. This requires deliberate effort, and I'm glad that at this forum, we made deliberate efforts for people who are living with epilepsy or living with people who have epilepsy to actually talk. And we have to have this constant effort to make deliberate efforts to involve them, not just even at sessions like this, but in our research, in our advocacy. They should be a voice for themselves and also be involved in decision making and policy. And then stigma. I'm not sure the neurologists experience it as much as I do, but for us, you see, we're a psychiatrist. The first thing I ask is that what you really want to do? And quite a number of us in the psychiatric fraternity still, and I think because of that shared trauma, a lot of times people with epilepsy like to come to us for treatment. So from my data, I found that quite a large number of people are doing treated, for instance, in the Accra Psychiatric Hospital, because we are all experiencing stigma. So it's something that we need to fight. Okay, and because it's a huge stumbling block in getting care. If you go to the districts, there are places now still in Ghana where if somebody should have a seizure, nobody will touch the person because they are afraid that if I touch the person, by the time I go home, I'd have also contracted epilepsy or seizures. And these are real issues that we need to look at. And then support for carers. I can't overemphasize this. Managing or treating somebody or living with somebody who has a neurological disorder is very, very difficult. From personal experience, I had a relative die recently from dementia, and I saw the challenges his wife had to go through within just a few months. And I can assure you that they need a lot of support, and that will come from us. So I would rehash things that we've said, or what we've said over and over till this point, that we need to work together. And I'm not sure which African country this comes from, but it says that the boat only moves forward if we all row together in the same direction. So I hope that we'll do that today and moving forward. Thank you.
Thank you very much, Dr. Samoa, for that wonderful presentation. Please, shall we give it up for him again? So we'll take our final presentation for this session from the TrapCap group. They are presenting on the transforming Parkinson's care in Ghana. I have the singular honor to invite Dr. Fifi Dodo to make that presentation for us. Please, let's welcome Dr. Fifi Dodo.
Thank you very much. Thank you very much. And then welcome all to Ghana. I'm Dr. Fifi Dodu. I'll be presenting on TRAPCAF, Transforming Parkinson's Care in Africa. This presentation was supposed to have been done by Professor Albert Apalu. Unfortunately, he's currently not in the country, so I'll do it on his behalf. So Transforming Parkinson's Care in Africa is a UK NIH global health funded research. A little bit about Parkinson's. Indeed, Parkinson's has been with us for quite some time, and as you can see, this is a drawing in the 1886. And Parkinson's actually is one of the second commonest neurodegenerative disease that we know. And it's characterized by disease of motor as well as non-motor. Motor is the one that we normally see, where predominantly slowness, and then it's also linked with other motor symptoms in combination, either as rigidity or stiffness, the tremors, walking and imbalance, and sometimes leads to fall. Unknowingly, the other things we do not expect, but the patients will actually be experiencing, and these are all the hidden stuff, are the non-motor issues, where they have a lot of neuropsychiatry conditions as well, and they also have a lot of autonomic dysfunctions later on. They also have a lot of sleep issues as well as wakefulness problems and also pain. So this is actually a picture from one of our rural areas of this man who'd seen to be having Parkinson's disease. Okay, so what are the current gaps in Parkinson's care in Africa? And as much as this disease has been with us for a very long time, I must say that awareness of Parkinson's disease, both public and even in the health sector, has been a problem. In public, for the public, they think that Parkinson's disease is like frailty from aging, and some even think it's a spiritual cause or witchcraft, and so that's a very big challenge. Again, I'm sure the previous speaker did talk about the challenges of neurologists in Ghana, not only in Ghana, but in Africa. Actually, in Africa, the neurologist about 0.3 per 100,000 population. That's one neurologist is equal to 3.3 million persons in Africa, which is woefully inadequate. And so also the health sectors pick it up later when it's in the advanced stages. And so it leads to a lot of diagnostic delays and treatment and all sorts of comorbidities and disabilities at the time. And this is especially where the patients walk in for all sorts of things, especially they are motor, non-motor, and they're treated for other things. Also, there's a huge gap in treatment, not to talk about the advanced cases in the surgical and all the neuromodulation things going on in Parkinson's. But the basic things, even as the oral medication has been there for many times, the levodopa is difficult to assess since we don't have a universal health coverage across the continent. And then even basic as neuro rehabilitation, physiotherapy, though it's catching up, is also a challenge. And of course, the big issue here is the research gap. It is a dent on the global global Parkinson's disease research, where a lot of African ancestry, especially with genetics, epidemiology, as well as even clinical phenotyping, is misrepresented. So actually, WHO actually did see the need for this, and so there's a driving strategies to curb this thing, and they came up with a technical brief on public health approaches on how to tackle Parkinson's disease. Parkinson's disease, the prevalence has doubled over the past 25 years. In fact, it's the fastest neurological condition causing a lot of disabilities and death worldwide. And so it's a huge public health problem. And so they say that it's an urgent public health response. An urgent public health response is necessary to meet the health and social requirements of people with Parkinson's disease and to improve the functional quality of life and prevent disability in the context of providing a universal health coverage. What is TRAPCAF? Like I said, what's the main aim? The aim is actually to transform the landscape of Parkinson's disease diagnosis, treatment, and care in Africa, according to all the gaps I did list about. It's been going on for the past 4 years. It's expected to end in August 2026. It's mainly funded by the National Institute of Health and Care Research from the UK, and it's mainly out of 7 main countries in Africa. Really was strategically chosen. You could see that from the northern part, Egypt is there, western you have Ghana and Nigeria, and the eastern Kenya, Tanzania, and then South Africa representing this data. A little issues about these things in Africa. This is a typical African setting, and this is one that is in in Ghana. So there's a long referral waiting time. Your minimum you can get is 3 months. And you could see, to see a neurologist if you are from all the way from the northern part of Ghana, until recently they had one neurologist in the northern region. They had to come all the way down to Komfanochi. Some come all the way down to the south. And the story is the same in other parts of Africa. Ideally, it was be a multiple disciplinary team where you have all the neuropsychologists, psychiatrists, physiotherapists, doctors, nurses, but really it's not so. And so it's a standalone clinic is also ideal. We tend to help in where I work with Professor Palu and Prof. J. We sometimes run some of the clinic on special days. They come on, we have special days where it's solely Parkinson's and movement disorders. We also have an epilepsy, I'm sure Prof. J talked about it. We also have a clinic for purely epilepsy. So that's one of the ways we want to sort of help with this. Of course, there are limited spaces. Talk about movement disorders. Neurologists are few, let alone movement disorders specialists. There are just few on the continent. And then we need to raise awareness for their interest too. Access to diagnosis, educational material counseling, and even support groups. We currently have a support group here, and I think it's not caught up with other parts of Africa. So these are the key actions of IGAP. Global health policies to implement Parkinson's disease strategies, advocacy and awareness, prevention and risk reduction, ensuring or strengthening the diagnosis and treatment arm to as well, strengthening the health and social system and building capacity and carer support. Most importantly, which we'll be talking about today, will be the research on Parkinson's disease. I think this is supposed to be a video, but I think we might not be able to play. This is a patient Prof. Palu saw many years ago, and the told was as frailty from old age. At the time, it was about 60, and he didn't understand, attributed to witchcraft. And so when this is the first time I think we had the movement disorder teaching session in Ghana, I think in 2013 or 14, and was picked up by the team, and they gave a dose of levodopa, and then the following day he was actually walking very fast, and was very grateful. So when it comes to trap calf, and I'll also be talking about GP2, which is more genetic, talking about the genetic basis in research. There's a lot of interplay among aging, genetic susceptibility, as well as environmental toxins and pathogens. Yes, when it comes to genetics, in terms of familiar genes, which follows the Mendelian pattern, just a few, about 5 to 10% of them are actually follow that pattern. Majority of them are sporadic, but you can see from this graph that it's merely in the childhood where genetics plays a very important. And as you go on, we have a lot of environmental toxins, and we also want to understand what's the risk factors in our part of the world, as well as the interplay between the interaction between genes and the environment. So these are all the research questions: prevalence, risk factors, in diagnosis, phenotyping, management. This is the Makuna trial, which was doing, that's the Makuna purine is an herbal, actually it's a plant-based, which Prof. Palu and then Italian and Prof. J, I think, and then Prof. Safo did on a trial on these ones, which shows to be showing a lot of effects using the herbal drug called Makuna as well, and also listen to the lived experiences. See the representations of the countries that are participating in the research, and these are the main research questions. What's the burden? We do not know as of now, that's why we need all these stages. What's the rate of Parkinson's disease? How can the rates be improved? The affordability, the sustainability of treatment. It's not all the drugs are on our health insurance, and not all the patients are even insured. How can the quality of Parkinson's disease management in Africa be improved? And then the unique risk factors. We want to actually understand the genetic, like I said, and environmental risk factors when it comes to this too as well. What about clinical phenotyping of Parkinson's disease? Apart from the idiopathic ones, we have other atypical ones we do not know, and so that's what we want to know. What are their current lived experiences of people of PD and their families in Africa? So to keep up, these are the websites. This is a website of the TRAPCAF, and they update new information on it. This is a protocol for the study, and this is a trial registration as well. And okay. So indeed, the first time the 7 representative countries produced about 1,000 Parkinson's disease patients with 2,000 controls. Ghana had about 3 sites, Accra the site's PI was Prof. Palu, Kumasi by Prof. Safo. And then you can see in Tanzania had 2. Most of them had single sites. Okay. What were we collecting? Basically, the cohort. Like I said, we're talking about the typical Parkinson's disease as a idiopathic type. We also wanted to know the atypical representation in our part of the world, which we know about the PSP and the rest, and also, of course, the healthy controls, so it was about ×2 of the actual cases. And also the monogenic families, like I said, it's been known that about 5 to 10% of them are familiar, following the Mendelian pattern. We want to know what is our type. The clinical data actually did both the epidemiological studies, demographies, environmental exposure, clinical history, diagnostic criteria, their motus and non-motus as well. And then also biological samples with the aim of looking at genetics, the genetic variants in the part of the world. This was the questionnaire. The minimum the patient could fill themselves, the minimum plus the question the patient again could fill, but with just some few inputs for the doctor. But the core and the extended mainly were done by healthcare professionals. So there's a GB2 TRAP CAF Plus, which is also ongoing, and then they're including 7 additional countries, and I'll be talking about GP2 very soon. With availability of therapies and services on the continent, it's not so great, apart from physiotherapy, and these are general physiotherapists and not merely even a movement disorder physiotherapists. Like I said, you do not even have to talk about surgical management here. It's very few. Even with specialized clinics, also again very few. And so even with the nurses and support groups, it's not encouraging on the continent. What are we currently doing about this? How can we build capacity within the healthcare system? In fact, I'm happy Dr. Chawi is here. She has been an active member of the Movement Society, and they've come up with a lot of educational programs. I have been to one. There was one in Tanzania in 2019. There was another one in Egypt, in Nigeria, and previously there was one too in Ghana, and that's what we are trying to do. What are the lived experiences and awareness of these patients? There's a lot of frustration with physical and psychological as well as economic consequences of the illness. They are no longer working. Understanding of PD in the community is very, very limited. Like I said, they are attributed to all sorts of things. And they need to highlight an urgent need for Parkinson's disease awareness and intervention. There's a lot of stigma, and we've talked about, just like in epilepsy, there's a lot of stigma when it comes to Parkinson's disease too. So this is a participation record form that you have to fill. It's quite extensive and it can take you about sometimes 2 to 3 hours to fill this form. What is GP2? So GP2, again, it's merely, this is the Global Parkinson's Genetic Program, and then it's mainly, the research is mainly based on finding the genetic variants of Parkinson's disease, with emphasis of areas with underrepresented, like Africa. Most of our ancestries have we don't have much genetic representations when it comes to Parkinson's disease. Most of the genes we know out there are all from the Western and high-income countries. And so we needed GP2 for Africa to initiate this. The first meeting was in August last year in Accra, and the next one will be in Kenya this next month. What were the objectives? The objectives to scientific, like I said, to actually understand the genetic basis and its interactions with the environment, about the capacity building in terms of even training neurologists to become more genetic experts as well, and also infrastructure to carry out a lot of research to bridge the disparities even within Africa, not alone to talk about the high developed income countries, and also to bring about a lot of policies to help shape the landscape of the care of treatment of Parkinson's disease. So talking about shaping a better healthcare system, to bridge this gap in terms of genetic, there's a lot of data-driven policies in neurodegenerative diseases here, including Parkinson's, which we want to do. There's a lot of public health awareness and early detection campaign, and as well as also universal health and telling, and also reducing affordable medications and costs when it comes to Parkinson's disease. So this is a transformation opportunity for us to represent. There are currently a lot of genes that has been, not a lot, there are positive genes that have been found in GBA1, and they are looking into it, and we hope to have more good outcomes and knowledge from this research. Again, when it comes to movement disorder society, what to do to improve the African continent and to help with management of Parkinson's disease. These are some of the inputs by Professor Peter Palu and Lara. They decided that they do a lot of webinar sessions, demonstrative videos, short lectures, and these are for even non-neurologists to really have an input. And also depends, and they also need to do leaflets and infographics, recognizing common movement disorders. And also, yesterday I filled a survey on the knowledge gaps, and I realized there's a lot of knowledge gaps even in our part of the world. This is one of the Movement Disorder Society Africa. I think this is in Egypt. And so there's a lot, when you go to the website, membership for trainees are free. And there's a lot of education, podcasts, education sessions, and materials on the Movement Disorder Society website. Okay, so coming back home, there are a lot of training ongoing. Last month, TRAPCAF again did a training workshop, which was done by the PI site, PI Prof. Palu, and my colleagues, this Dr. Brodimens and then Dr. Dodd Glover, as well as we have a neuroscience nurse attached to the Parkinson's, attached to our Movement Disorder Society, which she's also here, and a physiotherapist. So they trained non-neurologists, general practitioners, internal medicine physicians. They trained the nurses as well as physiotherapy during this session. It was quite a useful one. I've talked about this. There are a lot of things on the site we can actually look out for. This is the Accra team. You can see Prof. Palu and the team here. And then these are the people helping with my colleagues, Dr. Dodd Glover here. They are helping with the data with both the GP2 TRAPCAF plus as well as, and they've done an awesome job so far. Okay, so this is international and this is mainly in the UK. And we can see some of our African colleagues. This is Professor Okubadejo from Nigeria, and we have some from Tanzania and Professor Palu. So this is international, and then there are colleagues in the UK too as well. Okay, thank you very much.
Thank you very much, Dr. Fifi Dodu, for that wonderful presentation. We want to move away from the presentations and then going to change the face of or into more of a discussion. So we want to now move into the panel discussion on the advocacy. Yes. We want to quickly move into the discussion session, and to chair this session will be Dr. Levina Jima from the WHO. She will moderate the discussion. And we have an interesting mix of discussants from the Ministry of Health, from Ghana Health Service, from civil society, and I think we'll have a wonderful discussion with this mix of discussants. So we have Dr. Richard Asamoah. Please, let's give it up for him. Dr. Fifi Dodo, you have to join us again for the discussion. Yes, please. Yeah, so we have Dr. Fifi Dodo as well. Then from the policy side, from the Ministry of Health, we have Dr. Adam Araman. Yes, please. And then finally, we have Prof. Patrick Eje. Prof. Patrick Eje will join us for the discussion as well. So I hand over to the moderator for the session, Dr. Levina Jima. Dr. Fifi Dodo.
Good afternoon. Just checking. Please, can I be heard clearly? Good afternoon. So this afternoon, we have heard a number of presentations, and we are talking about epilepsy and other neurological conditions in terms of the IGAP implementation, and we want to look at our local context. And so, as has been introduced to us, we have a team of experts in their fields, as well as Ministry of Health representation to dissect the area. And so would like to talk to our ministry colleague to tell us, we know that Ghana has set an agenda in terms of prioritizing non-communicable diseases, and which includes mental and neurological conditions through the establishment of the Mahama Cares and the free primary health care and other related policies. And there have been a number of high-level interactions at different levels, local and external, stressing the government's priority. And so I would like to hear from the ministry, how at the ministry level we are prioritizing their neurological and epilepsy-related conditions in the context of government policy.
Good afternoon, colleagues. So, from the Ministry of Health perspective, quite a number of issues have come up. But one of the things that has come up strongly here from the discussions that we've had is issues that relate to policy. And most of the policy issues that has come up, as some of them are being addressed already. And just a few weeks ago, the ministry finalized the evaluation of our sector medium-term plan spanning 2022 to 2025. And then we have actually put up a new plan, which is also spanning the period of 2026 to 2029. In the policy priority areas, NCDs is quite significant. And if you look at this year, most of the budgeted allocations from GOG, it is now a policy of the Ministry of Finance that all budgetary allocations must come from our sector medium-term plans. And so this year, 2026, all our budgetary allocations are drawn from our sector medium-term plan. And if you look at our sector medium-term plan, the Mahama Care Program has captured quite a number of non-communicable diseases. It has also highlighted some of the issues relating to mental health. But one thing that I would want to put out is that this issue that has been raised up quite a number of times relates more to, if you like, you will say, is the absence of a national policy framework on epilepsy. And I think quite a number of the issues that are shared, some of the issues that have been discussed here. So along the line, as we speak about it, maybe we'll speak more on those ones. Thank you for now.
Okay, so that's a lot of big English. We have people with lived experience and they are carers. How does that translate into what they have heard about non-availability of medicines, the fact that we don't have enough specialists to take care of them? How does all these policies translate into tangible change in their lives going forward? What does it mean to the ordinary person, what you have just put forward?
So what it means is that You see, when you prioritize something, it means you back it with the financial resources. Now, the uncapping of the national health insurance is one significant policy issue that is set to make more resources available to address some of these issues. And so when you look at the issues relating to the tangibles, as if so to speak, that how does it translate to the tangibles and what will people see? What I will say is that in previous practices, what we will find is that a lot of the payments, non-payments of providers, services, and what have you has often delayed. So sometimes you don't have essential medicines that are available in stock to address issues that are urgent. So some of these things are being addressed. Once we uncap national health insurance, what it means is that significant resources are available and we are able to pay for services provided as soon as possible.
Thank you. Thank you very much. I think we would like to bring to the stage Dr. Chawe to represent civil society organization. Dr. Chawe is a neurologist working with the 37 military hospital and also represents civil society in the neurologist field. You're welcome. So to Prof. Eje, you've led this beautiful research collaboration. We want to understand all that evidence you've generated. How does this data translate into better evidence to support all the advocacy we are trying to put forward for government to prioritize neurological conditions?
Thank you very much, Lavina. I think if you look at some of the things that we've said already about our study, using the current, it's tangible evidence. The tangible evidence that persons living in Ghana have high levels of, and these high levels of stigma influence their health-seeking behavior. And this has led to a high treatment gap for persons who have epilepsy. Also demonstrated that through implementation of parts of the mental health image gap program by the WHO, we can effectively train primary care workers in identifying and treating epilepsy at a primary care level, which all the presentations you can see improves access to care, improves diagnosis. All these leads to what? Reduction the treat that leads that means a higher level of persons who have epilepsy will be treated and reduce the burden of epilepsy in the country. And we all know that reducing the burden would improve economic outcome for the whole country. So the study has come out with tangible evidence, and that tangible evidence can be something that ministry through its policy wing can rely upon and what improve care for persons living with epilepsy and other neurological conditions. You remember what Dr. Dodu presented about even moving away from epilepsy, trap cuff, and the same education and to care workers diagnose Parkinson's disease and related conditions, improving care for persons with Parkinson's. Coming back to our study again, we've come to realize that persons that take care of epilepsy patients have very high levels of stigma. That also affects their economic output. And so if we put in a policy to take care of persons living with epilepsy, it means the carers may have that freedom to also go about their work, increase their economic potential, and increase the economic potential of the whole country. And the evidence is there. look at what we did previously, we didn't have this tangible evidence to prove. So it is difficult. It was difficult then, but now, if the evidence is there and all the numbers are proving to it, I see no reason why the ministry cannot take hold of this and drive, equate resources for persons who live with epilepsy and other neurological conditions. Thank you.
Thank you very much. So to Dr. Adea Samoa, you were the focal point for the survey on IGAP for Ghana. And I believe that that's exposed you to a wealth of on-the-ground challenges as well as opportunities we have. As a clinician, in your experience, how can health professionals' attitude to neurological conditions be shaped to improve on advocacy as well as clinical care?
Thank you very much. So from a clinician and a part-time educator perspective, I think there are two major aspects. We've talked about stigma. It would surprise you that even among healthcare professionals, some of the beliefs and the thoughts that we think are more related to or directly in the communities also exist among health workers. And so it also consciously or unconsciously shape how they address and attend to people with mental health and neurological disorders. And so then you would have challenges with care, and particularly in terms of follow-up care. The other aspect is also that one of the things that I have noticed throughout is I heard of a term before it in Kenya and South Africa, neurophobia. There's a fear of neurological disorders in teaching and learning. So I'm sure one of the reasons why you have so few neurologists, because you hear neurology, hey, that's the first thing that comes to your mind, that how am I going to become a neurologist? Recently in psychiatry, we are trying to push, for instance, neuropsychiatry. And for some time now, it's a challenge getting anybody wanting to have interest in neuropsychiatry. For a while, there were just two of us studying neuropsychiatry as an area of interest. So it's another area that we have to look at, that we need to break that fear, that anxiety regarding neurological disorders. And that starts from as early as our primary and junior high educational level. That is where people start forming what they want to be, want to do in future. And if you're able to get their attention there, with very simple programs and activities that can make them realize that it's not that difficult. You have a brain in your head, so you're already on the right track, because neurology is essentially about nerves and brain. So if you have one in your head already, you're already there. So that's one area. The other aspect is, again, stigma. It starts from that level, okay? Because even at the primary and junior high levels, there are children living with epilepsy. And some of them, they have friends who, in fact, they have mates who won't touch them, and they've been told from home that you don't touch somebody who has epilepsy. And so this is at the points that I think that as much as possible, our focus actually starts from that level, the formative years, and then we build on to get a change all the way to the top. Thank you.
And I would like to ask a second question to you and to our ministry representative. As a professional, we know that we have inequitable distribution of specialists in our country. How can we address this issue from your perspective? And then same to our ministry colleague. As a ministry, how are you ensuring equity in terms of distribution of the professionals we have?
So I think we also look at it a bit from a personal perspective. One area that I hope the ministry will talk about is incentivizing people to move away from the urban areas to the rural areas. But in the meantime, we can also start harnessing information technology opportunities. Now I'm able to sit in Accra and do consultations across Ghana. I have, because we do these MHGAP, MHBSS programs, there are primary care and community mental health professionals who have our contacts. Sometimes they will call you to join in a consultation and things like that. So those opportunities that are there. MHGAP program has helped in task sharing. I don't like the idea of task shifting because they're already overburdened. So if you say now you're shifting your specialist care to them as well, then they push back. So we are sharing. At least you can do initial assessments, start the management, and then we can work together from there. So that's another perspective. And then again, looking at IT, looking at developing, for instance, artificial intelligence and AI apps. We have worked on about 2 or 3 in mental health that show some promise. So it's another area that we can look at. Because one of the challenges that we have when we do the image gap is that he says that my clinic is already so booked. I'm not now going to pick the image gap manual and I'll be flipping through and see, okay, so after this, what do I do? After this, what do I do? But if you have a system that's already keyed in, that can quickly give them a reference that based on these symptoms you have entered, this patient is likely to have epilepsy. So do this and this. That would help bridge the gap whilst you are working on getting more people trained and more people to move into the rural areas as well. Thank you.
Thank you. So,
I think with the issue of equity, one aspect or one angle is the use of communication technology to bridge some of the gap. The other part has to do with, from a policy level, more on how can we build incentives that will encourage professionals to move into deprived areas. And so with the incentive angle, the ministry has had quite a number, and some of them are being encouraged and are giving some kind of incentives, which when properly implemented. And we are actually going to take drastic measures on that, especially in our 2024-2025 planning phase. And so if you look at earlier, I spoke about our medium-term plan. I will encourage a lot of practitioners to have a look at what we have in that plan and probably try to work within the framework of it. We have quite a number of ideas centered on it. The other part, which is also a policy, is the issue of bonding. We are trying to push that angle because it is not proper to spend resources to train people and you cannot have them do the work that they are supposed to do at certain. So we would make sure that if you want to be trained to provide a certain critical service, you can be given the resources to do so, but you would have a bond that you cannot move to any other place, but you would have to go and serve that particular area. And I think we have had examples of it. It used to be when we had critical shortage of nurses in this country, that was implemented between 2003, 2006, where young nurses were required to go to their respective district assemblies. They had a bond, and then the assembly will pay their school fees and all that. And when they complete, they were required to be posted into those districts. And I think those are some of the things that can be used to address some of these problems. Thank you.
Thank you very much. So to Dr. Chawi, we have a number of interest groups, professional, etc., and some have been listed, some have presented. How can we strengthen these interest groups into advocacy tools to ensure that we have proper implementation of the policies and findings from such research that informs policy and practice?
So I think the special interest groups or professional associations are critical in guiding the narrative about our particular issues. So it has been mentioned sometimes, research, training, education. These all are the foundation for policy, number one. And we have to provide data. Policy cannot be created on lack of evidence. So we are to provide the evidence, make sure that the evidence is accurate and represents reality. It was mentioned earlier today how by Dr. Dea Samoa, how varied the input of information is in the health systems. So you can have treated as stroke. You can have a whole bunch of different and sometimes incorrect annotations. So it's up to the professional societies, the civil society groups, number one, to start that research, see where the problem areas are, and based on, first and foremost, numbers. So epidemiology, how are things being entered? Why are things being entered incorrectly? We also identify the gaps, the educational gaps in primary health care within medical school, because often the problems start there, or just as Dr. Deasama also said, starts even before that, so that we can make sure that disorders of the nervous system, epilepsy being an example, are properly recognized, properly counted, and then we can base all our policies on it. So we, as a professional society, the Neurological Society of Ghana, are going to, that's our main mandate, is to make sure that we are increasing awareness of neurological disorders. We have to start talking about neurological disorders not just as disease, but as important things for the government, for the population. When we talk about brain health, instead of speaking specifically about disease, because everyone's like, oh, no, that's not me. Oh, I don't have that one. I don't have this. So you don't have a vested interest. But when we talk about brain health, we are all stakeholders. Every single person is a stakeholder. And from our brain health, it determines our productivity. It determines how far we can go in education. It determines what we are able to do as a society. And so it's in the government's interest to make sure that its population has adequate brain health. And then we provide the numbers about disease and the places where disease can occur so that we fix it. We have to also learn to move away from a curative model of medicine to a preventative model of medicine to maintain that brain health. And then when it comes to policy, again, it has to be so that we end up with prevention of disease and then management, appropriate management of that disease when it will unfortunately inevitably occur.
Thank you very much. In the interest of time, we'll give the last word to Prof. Patrick Ejay based on what you have shared with us through your research. How does our discussion fit into going forward in what you've been able to share with us from the EPINA work? And then we'll bring the discussion to a close.
Thank you. We are looking at advocacy in light of the EPINA work. And it's good that we brought the ministry to commit to the fact that the ministry will look into equitable distribution of specialists within the Ghana geographical area. The ministry is also keen on getting all the incentives that the healthcare practitioners need, which is also very important. We've also just heard that the ministry is also looking at investing more resources into chronic conditions, which epilepsy that we keep studying is included. So that is a good point. But what we want to add to what the ministry is saying is we want the ministry to look at the information provided. The information provided from the study can help the ministry to further advance its interest in non-communicable diseases, and maybe they could start with the information provided from the study for epilepsy, and that could help move the care of epilepsy forward. If the study wants to say that from what Dr. De Asamoah and Dr. Chawe is saying, that there's a prevalence of 1% of the population living with epilepsy, technically that's over 300,000 persons that are technically at any time T supposed or living with epilepsy. And if you look at what the study is saying, that the carers are equally affected. So if For instance, every person has one carer. So that is looking at over 600,000 people being affected. And if each carer and person living with epilepsy is affecting several other people, so you can see that it's an exponential something. Nearly more than 1/10 of the Ghanaian population being affected by epilepsy because of numbers. We can say that with other diseases like hypertension, for instance, everybody has hypertension, but when we have such tangible data, this is very good information for the ministry to look into and help drive the course of care for persons living with epilepsy. And regards to professional societies like the Neurological Society of Ghana, which, as I sit here, I'm actually the vice president. It's a very good thing that we are now doing, and like Dr. Chawi said, we keep talking about trying to destigmatize the concept of neurology, where we keep talking about brain health as against making noise on the various forms of diseases. And we are still fighting the stigma of neurology as a subject area. And the good thing that we have done, Albert, myself, Chawe, and all, is we have now improved or increased the neurologist count in Ghana from 2 or so those days to 16 and still counting. So we are still doing our best and trying to destigmatize the disease, the subspecialty neurology. And as we speak, we've also had a couple of people whom we supported to train outside come back into the country in the ambit of neurology. So if we get the needed support through researches like the EPINA from the Ministry of Health, I do think that persons living with epilepsy may have such a wonderful time living in Ghana and having epilepsy. So that's what I want to say in regards to the study and this advocacy meeting that we are having. Thank you.
Thank you very much. A round of applause to all our panelists. Thank you so much for sharing your rich experience with us. And I believe that they've done justice to what we asked of them, and will revert to the moderator for the MC for this session. Dr. Adakwa, over to you. Thank you very much.
Thank you.
Please hold on. I would like to take a group photo of the panel. Thank you very much for that wonderful discussion, panel discussion on epilepsy and advocacy. So we heard from the policy side, we heard from the implementers, we heard from the research and civil society. Now we move on to the last session for the last part of this session, which will have to do with the other players with epilepsy. So this point will be this session will look at discussions around perception, challenges, and opportunities. And to help me do this, our chairperson or moderator will be Mrs. Sabina Isiama. She's a social scientist, and then she has done a lot of work around epilepsy care. And to help with the discussion, the panel discussion, we have We have Mr. Thomas Labi. We have Mr. Albert Boating. Because they are a couple, so Mr. and Mrs. Albert. Mr. Albert Boating and Mrs. Ivy Boating. Yeah. And then from civil society, and also she's also from the 37 Military Hospital, we have Dr. Achawe, who will join the discussion. Please, let's give them a round of applause as they. Madam Moderator, I hand over to you to your discussions. Thank you.
Good afternoon, everyone. It's a pleasure to be here this afternoon to moderate this section of the panel discussion. And we will start with the professional view on these issues. So we will start with Dr. Chawe. Dr. Chawe, we've heard a lot this afternoon about the challenges in epilepsy and neurological care. Can you please walk us through some of the major system gaps that exist?
Thank you for the question. That's not a happy question to start with. So the main system gaps, I believe, the person living with epilepsy faces is, number one, understanding that epilepsy is a medical condition that has treatment. So it's the first step. I should go to the hospital. When someone has chosen to take that step, or not chosen, they get taken to the hospital, as is often the case. It is then recognition of the problem by the primary or the first point of call in the healthcare system. In our environment, very often, if someone is brought in having a seizure or is having a seizure that it's not stopping, because we live in a tropical country, unfortunately, most things are going to be lumped in together, and the individual is going to be told that, oh, you have malaria or some other infectious disease. And the fact that it was a seizure that brought you to the hospital may often not get captured in the protocol and plan for management, and you end up being discharged once you're back to your normal self, again without a plan to manage the problem that you brought to the hospital. So number one, it is seeking care. That's the major challenge. And then number two, understanding and being educated when you have sought care that this is a chronic problem. There is management. It is sometimes lifelong, but it's usually long term. Yeah. So those are the first gaps. Then the next gaps that unfortunately our people face is availability of medications, and medications that not just are good for seizures, there are plenty of those, but have less side effects. You're able to go to work and you're not sleepy all the time. And then can you afford those medications? You're able to go to school, and again, you're not sleeping all the time. So that often poses a challenge when you want to prescribe a medication that you know is easier to take, has less side effects, will enable the individual to continue life as normal. The obstacle is, how can I get that medication? Then for many of our people, again, the stigma. Stigma is sometimes self-imposed. So there's the external stigma and there's the internal stigma. Often, parents of children who are having seizures will withdraw them from school, not because they are not doing well in school or they can't go to school for any particular reason, but they don't want their child to be seen to have be having seizures whilst in school. So that also, the internal stigmatization, the imposed stigmatization, causes quite a bit of obstacle for the person living with epilepsy. Sometimes it is a diagnostic challenge for the doctor, getting the right investigations, getting an EEG correctly read or even appropriately done in the first place, getting the right imaging when it is not so straightforward. The truth of the matter is, and we should, at every encounter with individuals who present with a seizure or recurrent seizures, in other words, epilepsy, is to let them know that Number one, getting the right dose of the medication and the right medication itself is a process. Sometimes we oversimplify things and the individual things. Oh, I've been taking my medicine for 30 days because that's what's written on the prescription. I'm still having seizures. Doctor doesn't know what he's doing. Or doctor knows what he's doing, but how come you're still having seizures? Doesn't explain that it's a process to get the right dose, to get the right medication. Not everything suits everybody. And at first point of encounter, we need to encourage the patients that most patients, about 80% of patients, are not difficult to treat at all, even at primary care level. It just takes time to get to the right dose, and most patients will do well, be seizure-free, and can eventually get off their medications with a few caveats, of course. And that education also is a gap because very often in our consulting rooms, there's not enough time to have that full conversation with the person living with epilepsy or the parent or the carer to let them know that number one, it's a process. Number two, there is hope. And number three, just because you still have seizures doesn't mean something hasn't worked. It just means we haven't titrated it adequately yet.
Thank you very much. For the primary healthcare level, you even hear nurses saying, I'm not trained to take care of a person with epilepsy. I don't have the experience to train a person to take care of a person with epilepsy. And even assessing medication at the primary healthcare level is a problem. So how do you deal with that? Or what has the policy
You're absolutely
to
right. Policy has to follow the programs that have already been done by the EPNA, the Epilepsy Society of Ghana, the Train the Trainers, the outreach programs. It is not true that a nurse cannot start management, but because of underlying policies that have been inputted, and sometimes some of them are decades old, yeah, that you can only access an anti-seizure medication if it is prescribed by a psychiatrist or it's prescribed by some kind of specialist. That puts an artificial obstacle into the individual getting care. A medical officer at primary care level or or what did they call them now? Physician assistant at primary care level, if adequately trained, and it's not that difficult, and we know from the programs that it is very possible, if adequately trained, can identify one, two, prescribe these medications, and then if the case is a challenging case, then know the pathway to further care. To be fair, a lot of our diseases that we make them sound very fancy and complicated are, if the individuals are trained properly, perfectly manageable at primary care level.
Thank you. But is there a way of organizing in-service training for such staff?
Oh, by all means. And again, it starts, as we mentioned in the other panel, it starts in medical school, and then programs, outreach programs, etc., train the trainers programs.
I mean, at the primary healthcare level?
Yes, in nursing school even.
Thank you. So, as we say, policies are not meaningful until we hear from the voices of the people who are directly affected. So, Mr. Boateng, we would like you to kindly walk us through your experience of living with the condition. What happened when you experienced your first seizure, and how are you going on with your medication and all that?
Thank you, Madam. Good afternoon for the audience and my big doctors from abroad who, through our care, you have traveled the whole to come here, and the big doctors who are taking care of us. I have gone through a series of very difficult, because the thing came when I was about 33 years. So when it came around 2007 to 8, I wasn't believed that this something has happened to me. So I was a little bit not understand. And it came, this question I will ask that after I finish, that what brought it, or what actually be the cause that bring the epilepsy or seizure onto our life. Because I remember I lost my job 2006, and I was so dramatic. I don't understand how the thing came, some huge debts and this thing. I traveled to some prayer camp to prayer to fast 40 days, thinking and thinking. So after that, when I came back from 2007 to that, I was, because my house, they have dethroned me. My store that I was owing, Okanshi, they have dethroned me. So I become possessed. So I was living with one of my friends. So in the night, one day in the night, when my friend realized something has happened to me, where I didn't aware. And it came another time when I sent to buy some rice to cook. When I was holding the rice to come and cook, I did not see anything. Before I realized myself, I was one of our friend's house. Then my brother started telling me what has happened. So from there, we consulting here and there. Told my father, my mother, they all take me somewhere. So I take it upon myself to struggle. To 2009, I was driving. I was driving at the taxi. I'm going around where I met my wife. He didn't know what has happened to me. He didn't know my condition. Then we are dating. So we continue the journey. Before that, then she too get to know what has really happened to me. So we continue. Before with that, the firstborn has come. We continue. He too, by God's grace, God empower her to stand by me. To a second from solution upon solution, we are getting some medication, but it's not adequate. And there we have getting about 3 children. Till we moved from East Legon, we came to OEB. There too, I was battled on that. Till we get to Ikumadodowa, where we are now. Is there Madam and his team, where my wife was serving, where he meet one of his friend. Then he introducing, because he know it is me, so he don't want to go straight. So he will pretend that it's somebody who hasn't that challenge. So my wife is very inquisitive, so he asked the woman, then he too came. Then they came to my store, they see me, then they introduced me. I tell you, by God's grace, when Madam came in and his team, then we started the medication. From there, 2 years ago, by God's grace, I have stand on my feet. I'm working as a security guard, and my wife is at the store. I leave the store to her. Then I'm working as a security. I have been working there 2 years and over. Nobody has seen anything. At time when the thing came, this thing that first, when at the beginning, even I was asleep. When the thing came, then when I wake up, he told me this has happened. I didn't believe. He said, this has happened to you. Where I see my mouth, then there's something. Then I realized that something has hurt me. So by God's grace, through the medication and the support of my wife, who has stood behind me, unless with this sickness you don't get a child, you don't get a wife to marry, but turn to my wife who has stood behind me. That's my
Thank you. Thank you, Mr. Boateng. But when you were talking, you were saying your parents were taking you somewhere. Can you mention those places that we were going?
I remember my father took me to one pastor at Techiman. We went and stayed there. It was a prayer camp. So I stayed there, giving me some drinks, some water and food water and this thing and that. Nothing came. The man told me, oh, for him there, even if the person is dead, why you can raise him. Oh, if the person is this, why you can do this thing to him. I did stay there, nothing came. Then my wife was so furious. Then I drove back to Accra around 2011 or so. I came back. So my mother too take me to Kumasi. We seek for some medical this thing for prayer camp and prayer and this thing. Nothing came.
Thank you. Mrs. Boatin, as a caregiver, your husband says you stood by him through thick and thin. Can you share your experience as a caregiver?
Thank you so much. I'm so much grateful to God for this opportunity that I've gotten. And I will say thank you so much to you and your team. As my husband said earlier on, that was so inquisitive. Yes, because I've battled so much. He started, somebody that you've seen somebody. Just imagine you've seen a man that wanted to marry you, that you've seen certain. Meanwhile, when I was so young, I saw people having certain things they say about it, criticize. Sometimes I can see, I've seen people dying. So I know what it is and how it is, how society criticizes such people. So when I saw it, I said, from frying to fire. In fact, I was disappointed. But a voice that I heard, I said, is the Holy Spirit, said, will you leave this man? What about if you leave him and something happened? Can you forgive yourself? And I said, then I have to stand by him no matter what and sacrifice. So I never told none of my family. None of them knew up to this time. I have to start taking care of him. It's not easy financially. I have to struggle here and there. We got married. And by God's grace, when we were doing all this thing, nothing happened by the grace of God. So none of the family knew it. But their family, they knew it. They left the man. Nobody was calling, thinking. Everything was on me. So I was so dedicated to God's work, going to church, praying. And then they said, then in our dialect, they will say, it's evil sickness. So thinking, out of ignorance, praying, fasting. And even the Bible said it. So thinking, praying, out of ignorance, thinking of even, I was not thinking of even the other side of it. How did I know? From East Legon. Just imagine, nobody talked about that. I never saw somebody even educating somebody about the sickness. All what I know is people are dying, people are criticizing people about it. When somebody even knows about it, oh my God, that area, that means your family, you are cursed. So from East Legon, Oyibi, struggling, and still, I have to give birth with him. I became more stronger than ever. From Oyibi, just imagine from rent to rent. I have to stand. It came to a point, I said, no. I have to stand so that we'll move. and we got a piece of land at Ayikuma. We went there. Little did I know that place was a blessing. I saw a lady. I was about to sell something to her when she was talking about the epilepsy. They go rounds. I think it's Madame, their team, one of their team. And I said, I even lied because I didn't want to say, can I confide in you? I said, I have a friend because I didn't want, we were in the same area so that nobody will know. I have to protect my husband. Even in the church, I can't trust anyone. So just imagine, I have to let this be very careful, make sure that this woman is somebody that I can trust. So by the grace of God, the lady was so good. She went forward with the team, the head. In fact, they came fast. They started working. They came to my house. And I was that's the time I was encouraged that at least I have a, because no family even called to find out how things were going. And even sometimes, but I still believe in the God I'm serving. So when they came in, they started first year by the grace of God in sleeping. When he was sleeping, I'm very conscious. When sometimes he'll be sleeping, I'll be looking at him like this, monitoring him. Sometimes I'll wake up downward here. That's the thing I've been doing. I'm used to it because of the sickness. So it came, I just waked up. When it comes like that, I just wake up and sleep. I have to position him well, then clean up, me after of the I'm used to it. So when it came, when he waked up, I said, why? Are you taking your medication? The medicine, are you taking? He said, I'm taking it. So, okay. Then you have to inform them about it, that it came once. So went to the hospital thing. And previous time, even when we got medicine, it was so expensive. Even I have to go and buy. I don't have. I have to find to get money to buy it. And even sometimes I'll be frustrated to the extent that I'll even misplace my phone. Because 2 days when I don't buy it, it can happen. And when it comes, oh my God of gracious, everywhere, anywhere, it can happen. And it's very shameful. Then my heart will be beating like this. Wherever I am, I have to speed up just so that he wouldn't, because nobody wants to touch him. Because of that, maybe if I'm not, I can get it. So closer. So the medicine have to. So when those medicine, we couldn't buy it, and in fact, Madam and the team came up. In fact, I was very glad. And by the grace of God, first year it was good. It came once. Second year, perfect. And he started working. He said he will find something to do. And I said, we thank God. And I will testify. No called me. Nobody have called me. He comes, medication, 2 months, 1 month, 1 month. Now it comes to 2 months, 2 months. So the prayer camp, they've taken much of money off from me. I was tired, but by the grace of God, I never knew. I said, they are my angels that they sent them to Ayikuma to save me and my husband. And now I can say, I thank God. Peace. I can have peace of mind. Now, I can see I've gone. Last time when he saw me, he said, Ivy, you've gone tough. I said, grace. I was slim. Then I was very slim. Thank you.
Mr. Labi. Mr. Labi was supposed to be here with the wife, but the wife is out of town. The wife is the person having the condition, and Mr. Labi is the caregiver. So, Mr. Labi, over to you. Your experience. You've shared a bit this morning. Is there something else you want to add?
I think that before I speak, please let's give Mrs. Boateng a round of applause. It's not easy I can understand her pain previously. Even before we started the conference, when I came, I was introduced to them, and then I had a chat with them. And I'm already loving the family because when I started this, I call it game. When I started this, I am a master of ceremony by profession, and I've been doing this for 20 years. But it will interest you to know that there were people who were making me understand that my career would die because of my association. Yes. There were so many things that I had. I remember there was a time before we got married, we were around somewhere Kolebu. We were just on a different assignment, not going to see the doctor. And then my wife had a seizure when we were by the roadside, just around where fire service is. And then so I didn't know, I was really a novice during that time. So I have to hug her, so because when it happens, she turns the head a bit, tilting the head. So I just was trying to make it, not to make it obvious to the onlookers. But this mate, I don't know where, he really saw something was happening, but he can't tell what it is. And the statement he made, he was like, I had a mobile love. And then in my head, I said that if you know what is coming from up, you find metal, heart, and way. Because he didn't understand. There was a time on my way to my father's place in the Trotro, it happened, and then 10 people, they started giving you space. I said, thank you, I love the space. If you like, go out of the car. Do you understand? And so I can understand, I can relate well to what she has gone through. And I want to applaud her every time because she's a woman. When I mean she's a woman, you will hardly find a woman who know the man has that condition and want to marry. And even in my gender, you will hardly find one who want to do this. So that is why I always want to applaud her for taking that bold step to want to stand by the husband. And I can tell you, this is just an evidence that our solution, the solution for people who are living with epilepsy, is not in the hands of the prophet. Neither is it in the hands of the prayer warrior or the prayer camps. They are not there. Those things are part of the human life. Okay, we pray. We all pray. Everybody pray. If you have the doctors, don't you pray? You pray. But when they get to the operation room or when they get to the consulting room, they are doing something outside prayer. They are using pen, paper, and that which God gave them to take care of people who are living with this condition. So I want to say that this is just one of the many diseases that have to be dealt with. The unfortunate thing is that epilepsy look weird. Yes, epilepsy look weird by its nature. The reason for which many people want to shun away from. But you see, I challenge and I applaud everyone here that the things that people shun away from, and especially these doctors that are dealing with this kind of, a psychiatric doctor say, hey, that your people have come. Oh. So they give you a name and they stigma somehow because even you as a doctor, after all the years you have spent to study, and then they call you one of them because you are taking care of them. We don't really have a problem. What is good about this is that you guys are changing lives. You are adding more joy to people's lives. Because I can just imagine what it's going to look like if she didn't show up. By now, things would have been looking rough. And I've had the opportunity to meet one young guy because of less care, both from family, friends, and he himself is stigmatizing himself. Self-denial, stigmatization by his own self. So it opens the door for others. And if you see his condition, sometimes I ask myself, will he get better? Will he get better? Because one point has led to one worst point, and it is looking like it's a point of no return. So I want to spend my time to congratulate you and tell you that we are all behind you. If we have to give information, if we have to direct you to the right place, we are going to do that. For me, I've traveled a long way. And me, now, as I sit here, nothing moves me. Yes. Me might be ashamed. Until there's nothing you are going to do. So what I need to do now is to encourage people like Mrs. Boating to stand strong. So one day when I retire or I die, you will be there to change or keep the narrative going, because I said that nobody knows what tomorrow is going to happen. I mean, what's going to happen tomorrow? If I live here today and I don't wake up again, at least in my heart, I know I impact someone's life, I learn, and what I do. Thank you.
Thank you, Mr. Labu. Mrs. Watson, you spoke about your husband's family and other people ignoring you and all that. What is the relationship with your children in connection with the condition?
Oh, of course. That also is another part. My elderly one will ask, when they saw it for the first time, they were afraid. Then I have to call them. In our dialect, I will tell them, don't be afraid. This one is not something that you have to be afraid. Daddy will be fine. When you pray, pray for Daddy. Pray for Daddy and pray for me too, so that I will get the strength to take care of him. Sometimes you can see there is one funny thing. One day I was in the house, I prepared food. We were about to eat. And this day, just a new side that we've gone to. So this where the floor is sandy. So I prepared the food. When I finished, and then he was sitting beside it. At once, it happened. And the neighbor boy came. He was around. He was playing with my little boy. As soon as the boy saw the thing, the boy ran to the house to tell the mother, Mama, something has happened to Daddy. So do you know, I have to be fast. And do you know, my husband too is that tough person. I can't carry. I have to find wisdom and I have to be looking left and right. That if somebody is coming, I don't want anybody to see in that area that we've gone to, how people will criticize. And I have to claim, I say, then I tell my little, the elderly one, help me so that we'll clean Daddy. We'll let him sit down. Not doing, the boy has already gone to tell the mother. So I have to hurry up, clean my husband. I was, you know, when the thing happens, the later one, when he calms down, he have to sleep for a while. He will go to sleep for a while before he come to it. So I was praying that, oh, Daddy, come back so that you can get up. I can let you get inside. But it's like he was still. So we were sitting around him so that nobody will see. The boy has already gone to the mother to tell. And the mother asked me, my son. And I said, oh, Daddy was tired. He even stumbled something and he fell. Daddy was tired. Don't mind this little boys. Meanwhile, that thing has happened. I have to lie. And I said, God, you know within my heart, I'm not somebody that lies. But for the sake of something, I have to. My little one, therefore, the little one there, sometimes when it happens, he's asleep. But the girl, I said, keep on praying. The girl, he loves the Daddy so much. So he always say, has Daddy eaten? Has Daddy taken his medicine? I said, yes, Daddy has taken. So they have become, and now they are happy. At first, they ask questions. When will Daddy be? Okay. But I keep on encouraging them. But the church, so when I encourage them, they understand with the word of God. But the church, when it happened, oh my God of gracious. I became more stronger. I will not give up. I will never let you. And some people will be just, one day I called Madam. I was frustrated. I was just cooking. We were having program. Cooking to come and give him the food. By the time I will finish with the food, they called me, Auntie Ivy. And I said, I know. I started shivering and I called Madam Savannah. I was confused. That time my phone got message. So they sent him to the hospital. I never talked. I never discussed anything to anybody because I don't trust anyone. The way they look at us, the way even they, my God, sometimes I have to stand behind him. I don't even care how they look at him. Some people, they don't even want him to get closer. Some people, the way they look at, even one time, my husband even told me direct, there is a woman leader. This woman, they doesn't like me. Now I said, I know, don't worry. Don't worry. And the woman always tell me that, you are hard though. And I said, you don't know what has made me to become so strong. If you know my situation, like you cry, when they give it to you, you will not be able to stand. So I have to sometimes, when they ask me, I said, oh, it's not, I will not tell you. but I know within me what is happening. So it's not easy how society, but I always encourage others. Those that I see, when I see somebody having it, now it encourages me a lot to get closer to that person and encourage that person, because I realize that it's opportunity to rather help the person. But the way and the mindset that they put it in their mind, that the moment they touch the person, they'll have affection. That's what they think. And that's wrong. They think that after all, as soon as they touch it, when it happened, and even the foaming, they clean it. At first I thought, but little did I know, it's wrong. Nothing will happen. You will be fine. And I've given birth, none of my children, they are healthy by the grace of God. Thank you.
Madam Moderator, can I just add a bit to it now? This is what happened in my home. My children were growing up. My wife started having epilepsy before we started giving birth. I never sat my children down to tell them, your mother had epilepsy. I don't know if they will even understand. But you see, this is what I was doing. When she has a seizure, all that I have learned from Prof. Ajay, Prof. Apalu, and Dr. Chawe, I do them. And they sit and they watch every time. I try to make sure that in my home, I create a very conducive atmosphere, environment, just from kitchen to the hall. So when she's going to have a seizure, we've talked about the aura, the things, the signs you will see before the seizure will come. So when you are in an obscure place, oba benya seizure, obe free hall, then you come to the hall and then relax. So this has been going on until one day, when I came home, she told me that something happened, and I said, "What happened?" She said, "I had a seizure, and Pearl did exactly what you do." And I said, "Really?" And then lo and behold, maybe God wanted me to see. I don't know if because of my name Thomas, God wanted me to see. And then it happened in my presence. And the moment it happened, before I could say Jack, my daughter is already up trying to put pillow here. And I was sitting in the chair like this and I was observing. I just observed what the girl did. And then I realized that I am not just raising myself, but I'm raising other people who are also going to do the same thing I do. So yes, gradually, you are going to help your children to understand this is daddy's condition. Gradually, we are going to teach you, as you are now in the circle, we will teach you what you need to do. Gradually, we are going to teach you to master that confidence. Because you see, for the people around us, whether church or whatever, we don't even care when it happens among them, and we don't even care who knows it, and we don't even care who want to isolate themselves from you. The door is your front now, you go. Yes, because it has gotten to a point where we need to take the power by our own self and then make people understand that you see, when you don't know what is happening to you, people treat you anyhow. But when you know what is happening to you, and you can spell. I remember I did a presentation, then somebody came to me and said, "Doc." I said, "Hey, who are you calling doctor?" I mean, I'm not doctor. I'm just like you. Because of the way I presented the whole thing. And because of these people I have learned from, I can stand, and if you don't know me, I'll do it and I'll go, and you think it is a doctor. So power or knowledge, they say, is power. And gradually we are going to get you that knowledge and your husband. I bet you, anywhere you stand, whether let it happen, who cares? Teach them what it is, and that is where they are going to learn knowledge.
Dr. Chawe wants. Yes, please. First and foremost, to everybody here and everybody out there living with the condition, every single person is a hero, and you need to understand that you're a hero and you deserve all the applause that is available. Even when you don't hear the applause is there. But I think the conversation that we've had has also highlighted a lot of the problems that we still face and the gaps in education that's yours and my job to make sure that we fill. So every year we know the Monday before Valentine's Day is World Epilepsy Day. We use that as a forum, and not only on that day, we use that as a forum to educate the public. We should be educating teachers, because sometimes the teachers are the first people who see children having seizures, and then the teachers can teach the children, so that if the children see another child having a seizure, they understand what it is. They don't necessarily become afraid. So the education has to be ongoing. When we as healthcare providers have an encounter with an individual, that too is an opportunity for education. Every encounter is an opportunity for education with our colleagues, with the patients, the people living with epilepsy, with the carers. Every encounter at every level is an opportunity for education. Then stigma. Stigma comes out of ignorance. Or lack of understanding, let me put it that way better. There was something that Mrs. Boateng said that I really felt her pain. She said it was shameful. Now that back to us, we have to teach the population, educate the population that you have nothing to be ashamed of. In our society, how many people do you know who say, oh, today I have a bit of typhoid? We're not ashamed to say that. And I have a bit of typhoid means I have been in contact with somebody else's poo. We're not ashamed to say that, but we're ashamed to say that we have hypertension. We're ashamed to say that we have epilepsy. We're ashamed to say other things. Nobody should be made to be ashamed of an illness that they have to no fault of their own, regardless of the disease. We're not going to go into nuances. You should not be ashamed. And so, great courage to you. Keep it up. And at every point of opportunity, as Mr. Labi has also said, you also have an opportunity to teach other people. Keep up the good work.
The discussion is becoming interesting, but we are also taking care of our time. But I want to ask Mr. Boateng, how do you cope with stigma? How do you cope with stigma?
Like I want to say, as my brother would say, I have put my mind that this sickness is not my sickness. And I always believe on that. So no matter what, I've been a trader in Medina and store more than 3 stores I've been handled. Some of them, it came at the store there. I washed myself. I sell. In the church too, it came. I stood myself. The following day, I was there in the church. I did not. So I put my mind, and I remember I went to one herbalist, and he was a herbalist. I didn't know, because that time around 2010 or so, we were seeking for this. The man said, oh, as for this one, brother, say if you come, it's just by 2 minutes, it's gone. How about those people who have asthma, who has cancer, who has this thing? So don't be worried. Don't think about it. Don't think about it. I take something from there too. So as for the stigma, I never thinking about what you say, but I believe myself what I will become, and what my passion, and what my vision, and what my purpose. I'm a pastor too in the church. I preach the word of God. I preach every time, every sermon. Give me, I preach. So my purpose is the thing that I am pursuing. So I know Paul said, no, nothing can cut me short from the word of God. Either I am deaf, either it has left one my eye, or my hand are cut. As for the sickness, I never think about that.
Thank you. Thank you. Mrs. Boateng, your last question. What support do you think caregivers need but they don't receive? What support do you think as a caregiver you need but you don't normally get?
Really need support. It's come to a point you have to be a beggar. That's not your choice. I'm very hardworking. And sometimes I always say that it's good to be teaching how to fish rather than to be giving fish to chew. But this is the case that sometimes where he's working, it's like we have taken it like a part-time so that he can be active. Even as at now that I'm saying 5 months, they have not paid him. So just imagine, as a being a parent, a mother, and when they ask daddy, daddy doesn't have, they will come to me. And I make sure, no matter what, a child has come to ask you something, can you refuse? Even as at now, one person is asking for something, you'll be going to write his exams, and they will be camping him. After I leave here, he starts, since yesterday, he starts asking me, mommy, what are we doing? What are we doing? Yes, he have to go for camping so that he'll be writing his BC. Just imagine. And what pains a lot that family, sometimes when you call them, what they think is, after all, you are taking advantage. I will not call. We caretakers or caregivers, we need support in sense that sometimes nothing comes from this side. What are you going to do as a woman? Sometimes when I pass through this side, it doesn't work. There is a brother that my husband has helped before. That he saw the sickness, so he knew a lot. That man has been so helpful. Sometimes when it comes to difficulties, the children, the education, I call. He will give me add support. Then, so we really need a support in diversity way, because sometimes when you just turn around here, we just lift our eyes to God and say, open a way where seems to be no way. When my husband said, I don't have, when they give it to him, he will give. When he said it, that, what will you do? By the grace of God, now he's getting better. And you are forcing him that he should give. No, I will not even bother him. So I have to work hard. Then continue so that the children will also feel okay. Because the moment they think about that, we are not able to take care of them. Then, especially the girl, I always pray that, tell her, never let her go and ask something from somebody. When she needs something, she'll ask. Even if I will go and borrow, I will borrow for her, rather than her going to borrow. And even the rest of them. So we really need in all ways, because when family doesn't come, who else? If you don't know somebody that you have to support you, then you don't know what to do again. Even school fees will come, feeding will come. Just imagine, and he have to eat too. Just imagine, sometimes with his medication, with the shop, I have to make sure I have to bring his breakfast so that he can take medication in the morning. When he said he doesn't have money, then you have to. Even if the children will take half, then I have to call the school and say, tell them what I don't even like is what I will do. Please, tomorrow I will come and give it to you. Then I have to share with the daddy so that he can have the breakfast. So, thank you.
Thank you. We are almost ending our section. And the last question to Doctor is, what do stigma and community belief, how do stigma and community belief affect care?
It is the first barrier. So it's the first barrier in seeking care, and it's the barrier of reintegration into society because of either perceived stigma or actual stigma, and the understanding that this is a medical condition, there's medication for this. Sometimes the individual is simply embarrassed to go with a prescription that has anti-epilepsy medication on it to the pharmacy, because God forbid the community pharmacist will now know that I am on anti-seizure medication. And so that sometimes stops them from going to seek it. So stigma causes obstacles for the individual. Sometimes it is the self-stigmatization that also adds to the difficulty in seeking care and being in society, being a productive member of society. But I wanted to add to what Mrs. Botting said about the support. There is often a significant limit to what we can do for any individual that has any condition. But I think in these particular kinds of illnesses, if we can remove the financial burden of the hospital visits, of the medications, and that being as part of policy, if our gentleman from the Ministry of Health is still here. Yeah, so if these things can be mandated to be part of the national healthcare, the insurance system, so that at least that part of difficulty in life and financial constraint is removed from the individual, because that alone is an obstacle to care as well.
Thank you very much. I know. Okay, you want to add something briefly?
When I started this thing, I said, what really the cause? Madam.
Yes, you did ask that question. I wish it was a simple answer. It seems like a simple question, and the answer should be equally simple, but it's not. Sometimes there is no known cause. It just happens. That's how the brain is malfunctioning. Sometimes it's because of a past trauma or past infection that has affected the brain, or a stroke. There are lots of different things that can be the reason. Sometimes it is just the disease. I think many individuals who have this condition get confused when they go to the hospital. They have a scan done, or they have an EEG done, or they have basic lab tests done, and then they're told everything is fine. So you're confused. If everything is fine, why do I still have seizures? The way we, and again, it's back to you and I, and the way we communicate with our patients, it needs to be clear that just because your tests are fine, we're not telling you that the problem is no longer existing, because that creates a cognitive dissonance. I am fine, but I am not fine. What does that mean? Yeah. So it is just the very fact, every single one of us in possession of a brain, so that's all of us, yeah, can potentially get a seizure. There are multiple reasons, including sometimes there is no test that shows what exactly the problem is. But it doesn't remove the fact that if you've had a seizure, you have seizures. If they keep happening, you have epilepsy. Yeah. But there is almost always, sometimes it's hard, but there is almost always, for the majority of individuals, the right medication, the right dose, or the right combination of medications. Yeah, but that's a conversation that should happen. And again, that falls back to the healthcare providers right from the very beginning, so that there's a clear understanding, so that years later, you're not still wondering, but why?
Thank you very much, Mr. and Mrs. Boateng. Thank you, Mr. Labi. Thank you, Dr. Chawe, for your time and sharing your experiences as well. Thank you, participants, for also listening. Thank you. We come to the end of our session.
Yeah, dear. Thank you very much. This wonderful discussion around epilepsy, and we have heard from lived experiences from the point of view of caregivers, those who are actually living with the condition, and then providers as well. I think one good thing about the whole EPINA project that has really brought about some of this enlightenment is the part that the project really had shown the community the pathway to treatment or to care, which is the medication. And if you see, most of the discussions that came out from our panel was that once the thing is, they are thinking of medication. Once they get the medication, they know they are able to live a seizure-free life. But then there are issues surrounding people living with epilepsy, because such people are not able to work sometimes. The burden of it, be able to get the financial resources to be able to continue care becomes very difficult for them. For instance, in our study, we found a very huge treatment gap in Ningo Pramprama and Shao Sudoku. about 70% treatment gap. And these are people with the condition who are not on appropriate treatment. There was a huge diagnostic gap that we found from the study as well. These are people who have not been formally diagnosed by the health system. That means these people are all seeking alternative treatment. They are not, assessing medical care as we should get it. But one good thing about the project is that all our participants and even the community that we have working, we have shown them that the way is to what? The pathway to care is to come to the facility and get treatment. On this note, we have earned our lunch. We'll quickly break for lunch. The lunch is where we had the snack earlier in the morning. So we'll go for an hour break, have lunch, and then we'll return at 3 p.m. Thank you very much. Okay. Please, can we have the last panel here for a group photo, please? Yes, please. Yes, please.
We'll see you very soon. You have to eat. Thank you.
That's fine. The other one is, I'm back at that on Saturday. I only came yesterday. You know, I'm not worried for a long time. The other one, which I'm a bit struggling with, Daniel is saying before his CHD2 discussion, he's 7, and he has been transitioned to medical services locally. I arranged for one more week because because we started to discuss solemnity, and he said we just need to judge from the epilepsy surgery service because we had a cancer to me a year ago. Mum has been on to the secretary saying that the local team have said we won't advise. That's not true. In Echo, the fellow, Minori, gave advice to start from us that. Yeah. Yes. I don't know. I think so. I mean, I don't actually know. And, you know, Mum's ringing in saying, no, you can talk us. I can't communicate with her. He's an inpatient. You know, that's just not on. So I said to Nicola, could you pass on that, you know, we haven't said that. We're still giving political advice. But the advice was to communicate with the adult neurology team in the morning. And she said she'd pass that on. But I don't know. I presume if they come through again, somebody will give advice. I mean, yes. Yeah. Okay. Fine. All right. Thank you. I just wanted to make sure there's no forcing. It is difficult in this transition period, and he is particularly difficult. There's no doubt about it. But of course, they go over to adult care, and they don't get the same input, so it's really difficult. Yeah, that's right. No. Okay, we'll pass that on. NHS even. Okay, so it's like you've seen before. Yes, yeah, Kristen's already asked me about these. These are twins with KCNT1, and I said I'd see them as a second opinion. And I've said this 3 times. And Kristen's asked me. Kristen came and said, oh, do you think Amy should see them? The family specifically asked to see me. I'm happy to see as a second opinion. Jonathan has written the letter, John Gazzian. So I'm happy to see him as second opinion clinic. I've been through this 3 times. Sorry, Suresh. No, it's all right. Yeah, bottom line is they were told to book it into my second opinion clinic. Is that okay? And they can have an adult side, they can discuss that they can have an hour and a half slot because it's twins. Is that okay? Sorry, Suresh, but well, I think Kristen makes it more complicated with respect. Well, no, I think Kristen was making it more complicated. She jumps on the bandwagon that I shouldn't see, Amy shouldn't see, because it's KCNT1. But I'm discussing it with her, so, you know. And never mind. All right. See you soon. Okay, cheers. Bye.
there's no need to aggravate it. That is the premise by which when Donald proposed. So I just needed further clarification from you. That so you already know my name and yes, I'm patient. I don't know what
Well, thank you. Hello. Good afternoon. And welcome to the last session of the program for today. So in the next hour, we should be done with this session. And then we wrap up and close for the day. So this session is basically going to be a workshop. We are going to have groups of 2. And we're going to discuss a few questions that we will pull up on the screen for both groups. Each group is going to be purposefully selected so that we can have good representation across the groups, so we can make meaningful discussions and have good suggestions across board. So please, if I put you in a group, or if we put you in a group, do not worry. We are doing that purposefully so we can have good representation. Okay. So we are going to go into our groups for 30 minutes, have discussions amongst ourselves. We are going to have some guidance. There'll be some group leaders, and you choose your own rapporteur. At the end of the 30 minutes, the presenter is supposed to, or one of you, you're supposed to nominate one person who would come up here and share with us what your group discussed and your thinking about the topics we are going to put to you or on the screen. Then after that, we all will deliberate on it and put it out as a brief for us as what is coming out of this. Is that okay? Are we clear with that? Thank you very much. So I would start by choosing. Fortunately, we have 2 Ministry of Health officers with us, which will represent the policy part of this discussion. And because we have 2 of them, we are going to split them into the 2 groups. So group 1 will just sit on my right, on the far right, the space there, and have their discussions. And group 2 would also sit on my far left and have the discussions. So the Ministry of Health participants, you can divide yourself into group 1, group 2. That really doesn't matter. You can be here, you can be there. I'm sure our WHO rep or our focal person, Dr. Richard, you'll be in group 1. And then Dr. Chawe, you'll be in group 2, if that's okay for us. And then the Ghana Health Service colleagues, Dr. Mrs. Mamata, the Director of Health Services at Pram, he's going to be in group 1. We had a director here, another director. And Dr. Mensah, is Dr. Mensah here? Dr. Mensah? I think Dr. Mensah was around, but he's gone. At the Dodowa, we have 1 district at the Dodowa, a representative. I need a representative from Dodowa to be in group 2. Do we have any here? Dodowa? Okay. Sabina is here. That you are here. Okay. The research team, Sabina is here, so that Sabina will join group 2 for Dodowa, representing Dodowa. The rest of us, please, we will say 1, 2, 1, 2, 1, 2, and then we are in the group. Is that okay? Oh, sorry, one last thing. Tom, you are going to be in group 1. Thomas, you're going to be in group 1. And then Mr. Jerry and Mr. Jerry, right? Okay, yes. And the wife, actually, will be in group 2. Okay, thank you. So the rest of us, how many are we left? Please show by hand, including Charles and Arjun. Yeah. Show by hand. Thank you. So we start from here. You just say 1, 2, 1, 2, 1, 2, and let's go. Please. 1. Good. Charles? 1. Lee? Lee will be 2. Okay. 1, 2. Yes. 1. Messi? 2. Ima? 1. 2. 1. Prof? 2. Yes. 1. Okay. Yes, those are the back. Who else? 1, 2. I think we are okay. And then the rapporteurs, you split yourself into the 2 groups for us. The 2 rapporteurs, you split yourself into the 2 groups for us, and we are done. So thank you very much. Ima and Mercy will be the guides in each group. Emmanuel is here. Mr. Dakwa, he's here. Please be up so that they see you. You are in group two. Group two. I am group two or one? Two. Ah, okay. Well, okay. So you're in group two. He's going to be your guide with the questionnaires, and then Mercy will be in group one. So thank you very much. Not wasting time. Let's go into the groups. 30 minutes. Thank you. So please let's split into our groups. Group two is here. So group two will stay here. Group two will stay here around there, and group one will be here. Thank you. Just 30 minutes and then. So. Yes. Yes, you are going to do that. Because it's a WHO program, yes. Eh? Topics. Mommy topics. Mommy topic. What's your topic? One is inclusive of inclusiveness. Inclusive of progressive into policies. And the other one is stigma, discrimination, and beliefs. Which one should go where? Okay, stigma will be here. Stigma will here. So group one, your topics are ready now. Ah, Nancy has a topic already. Yes, please, you're sorted out. Yes, I got you. I got you. Yeah, then you two take your side. Okay. Message. You want my intro this
to other aspects. So instead of having a bit of neurology in aging policy, a bit of neurology in education, let's have a neurology policy that covers all these and then are linked to the national policy on education, on an aging, and so on. So that's, I think, where we should start from. And I think do we have some lived experience with us in this group? Yes, so we could start from them telling us maybe what, from their perspective, would be useful to them in such a policy. I don't know if we all agree with that.
Okay, so me. let me let me just say that there are instances where there are few challenges when we have to look at individual policies, because we are also promoting integration.
Yes.
Even though sometimes when you integrate it,
okay,
we might not see it. At the same time, if you do it as standalone, it's also a challenge because everything is kind of like put together. So the Ministry of Health has policies for, say, communicable, non-communicable. So we have a non-communicable disease a policy and a strategy.
Okay.
That looks at and some prioritized conditions like the cardiovascular, the cancers, and other things. Yeah, but you see that also the epilepsy manifestation appears a little bit as though a mental health disorder, even though it's a purely neurological condition that requires a completely different way of managing it and all that. Yeah. So, in as much as I may align a little bit to you, so that we could integrate everything that we are looking as far as neurological conditions are concerned, I'm also a little bit concerned that if you take that as a standalone, its integration in other policies may also be hindered. But we can still have it and then integrate it in other policies. So, for example, if you are talking about aging, because of the impact of what happens to the brain and shrinking and all that, then people may exhibit some kind of some seizures, epileptiform seizures and things like that. It would appear there. In trauma, people who have had head injuries may also exhibit some kind of seizures. And they're saying that anybody who has more than one seizure, can be classified on the side of epileptiform seizure. So I would say that it's just also prioritizing. And the other thing we're talking about is strengthening access is also the financial part. I don't know whether National Health Insurance Authority was invited, but in terms of medicines, if it's going to be readily available to our patients, then we are looking at universal health coverage, saying that we shouldn't let financing become a barrier at the point of use. We know somebody must fund it, and healthcare is expensive, but at the point of use of the service, it shouldn't be a burden. So if it's covered by the National Health Insurance, then that is fine. The Ghana Medical Trust Fund is also there, and so aspects of it, I do know some people who consistently, having a seizure, and the medications are not covered. Some of them are not covered by national insurance. These are opportunities as we drive these things. We could also shift it because the non-communicable disease is chronic and possibly can be incorporated into the Ghana Medical Trust Fund. So I'll just say that these are the areas that maybe initially just to mention that. Yeah.
Okay. Thank you very much. Are there any other views that's... Yes.
Question.
Okay. This is pass it on.
So in some countries, disorder, mental health disorders is free, so you can get access to medicine free.
Yes.
Even outside the insurance system.
Yes.
Does that happen in Ghana?
So that's by a law, that's what's supposed to be happening in Ghana. But my colleagues will agree with me that it never doesn't really happen. So eventually, the clients are forced to pay out of pocket. So there's supposed to be established a mental health levy, a mental health fund that's supposed to cover mental health conditions. And so you should be able to walk to any of the mental health facilities and get treatment for absolutely no cost. Unfortunately, it doesn't happen. So the facilities, because the funds are not disbursed, so the facilities have to run. So they are forced to charge. So that is why eventually there was a discussion around putting it under the health insurance scheme. So it's at least covered, and so those who have the insurance can now get access to care. That also has hit all kinds of bottlenecks. On paper, there are 4 disorders accepted under the health insurance scheme, but in practice, we haven't seen it being rolled out. So that's some of the challenges that we have when it comes to funding. Yeah, we say that it should be free, but then we don't. Being free means that somebody has to pay for it, and that somebody is the one who is not paying for it.
Can I add something to it?
Yeah.
So, I mean, one of the difficulties of also adding it to the benefit package was because there's a program for it. So it used to work in the past, and now there's a challenge. If you take malaria, there's a program for it. We're getting the medications, in terms of donation. If you take HIV and TB, we're getting these medications. So putting them on the national health insurance at the time was a non-starter because there were already systems in place to manage it. But unfortunately, things are not working the way it's supposed to be. Malaria, for example, is reimbursed. So people were pushing that, why don't we add these things? The medications for taking care of persons with some mental health or neurological disorders, some of them are already covered by the insurance. The challenge is with making a diagnosis and linking it to it.
Exactly.
Because the DRG specifically says that there must be a diagnosis. So what I know some of our colleagues used to do, which was what I do, was that you try to coin a certain diagnosis which is on the National Health Insurance benefit package, that will allow that medicine to be prescribed. For example, carbamazepine. If you diagnose somebody with epilepsy, you not get the medicine, but it is used for something else. Then you have to make sure that. So those were because it was supposed to be given for persons with epilepsy, or persons with mental health disorder. It was epilepsy. No, other mental health disorders. They were supposed to get it on their program, and that is why it was not included. But that is where we are making a case that what can we, because the program is not sustainable, but the national health insurance is more sustainable. So, but because the law that set it up was not, so it takes a little bit of how we migrate different conditions. If you notice that cancers were not covered currently, breast cancer and cervical cancer are supposed to be covered. 4 childhood cancers are. So we working towards trying to see how, but the rest of the things that are a bit more chronic, which cannot be rolled onto it, would be moved onto the Ghana Medical Trust Fund. So all cancers are going to be moved onto the Ghana Medical Trust Fund, and then you leave the others. Even though the funding for the Medical Trust Fund, 20% is still coming from the National Health Insurance scheme. So these are, but I just want to mention that it's the advocacy that will push, because more or less everybody is pushing for their medication. I mean, everybody is pushing, and the National Health Insurance is going to die if we load it like that. But there's advocacy that would push, will push for these things to happen. The aspects of it which would have been good.
Who would push? Who is this person that would actually?
Oh, so we have for example, neurological disorder, maybe association, because these are you see, you are taking care of your patients. You see, at the policy level, sometimes you might not see, but how these things are rolled onto is a clinician is seeing patients and realizing that the outcomes are poor because we prescribe, the people cannot afford it. So then they begin to make these, the push in terms of advocacy that if we really want to see good outcomes, then we need to make sure that the medicines are available. Well, first making it available in the country, and then also financial availability in terms of access, then they can also have access to it and to use it. So meetings like this, I'm coming from the ministry, meetings like this, it's also telling me something. And then when there are opportunities for us to revise and things like that. For example, the National Health Insurance, that is why I'm a bit concerned. If National Health Insurance was here, they also pick some of these things, and take it back. So maybe next programs, in terms of mapping the stakeholders who need to be there, it's important that, we get some of these other persons. So, okay.
Hello. Just to add a little bit to what he's saying, apart from advocacy, I think experts mapping the indication with the medication too should be looked at. Just like he said, there are some medications that are already covered.
They can hear you.
Some medications are already covered, but not under epileptic indication. So that aspect, if it had been cleared, then a lot of the patients would have already have access to anti-epileptic medication.
Okay. I think what I actually meant with that was that there are rather some drugs that are covered under epilepsy, but not covered under mental health.
That's right.
So usually you would have to give, for instance, a diagnosis of a seizure disorder epilepsy to get to a patient who actually has, for instance, bipolar disorder, where we use the same medications. Uh-huh. But then again, what can we do, particularly when it comes to the drugs, because there's still quite a limited range of drugs that are covered under insurance for epilepsy. Okay. I do have neurologists here because I know that they, yes, yes, yes. Evaporate. Evaporate. Yes, yes. But then so it means that of these four, if you have an absence seizure, then your options are quite limited if you're under insurance. Sure. Because typically you want to use maybe ethoxycamide, which is not covered, sure, or Keppra. And Keppra is one of those ones that I think now more and more neurologists are prescribing, but it's not covered. So then from these discussions, what do we do? Because I actually noticed that when I went to the districts, most of them just have carbamazepine and phenobarb. So if your seizure is not being controlled under any of these, then you are stuck. So what can we do with that? Yes.
Let me just make it very brief. You see, this what can we do question.
They can't hear you.
This what can we do question has been asked many times. I can remember the program we had at GIMPA. I think that was 2002 or so. No, 2012.
Yeah.
2012. Yes. Then it was Segbefia who was the health minister. And this same what can you do question came out. Like you mentioned, we have 4 of the anti-epileptic drugs on the national health. So I remember those days when it was not very clear. When we go, we buy. I have to take money and make sure I buy until when national health became more potent. It started covering this carbamazepine, phenobarb, phenytoin, sodium valproate. Now, when a woman who is having epilepsy is pregnant, you cannot give the woman any of these 4 drugs except carbamazepine and what do you call it? Folic acid. Assuming this woman is not doing well on carbamazepine, it means that that woman will be having seizures during pregnancy, and that can lead to the loss of the pregnancy. Now, we also realize, even though as a pregnant woman, it's not so safe putting them on Keppra. Aside pregnancy, we realize that Keppra was helping someone. Some of them are not fitting well on the carbamazepine. Even carbamazepine, they have different, they have the generic and the other type. So you go and the generic is not working for you. Maybe the other one is working for you. But because it's not on the national health, they tell you, we don't have this, we have this. You say, we don't have this, we have this, manage that one. That hasn't really worked. It has really been a problem. The reason why a doctor will see a patient and maybe during the month he had only 2 stages. And then he knows very well that he has done a lot of talking and diagnosing, and he will return back the next month and he's having 5 seizures. And you don't understand why. The person is still doing very well as far as lifestyle is concerned, but it is because of the drug. So we'll do something about it. This will do something about it because I've asked several times. Why are we not adding Keppra? Because it seems I see a lot of the people I have seen, Keppra is helping them. It's helping them to stabilize their seizures. And it's not part of the national, and they don't have money because I bet you, before 2007, where I got married, my wife lost her job a year before we got married. And why? Because of epilepsy, because she had seizures. And when she had seizures, the boss was not there, but the boss was told. She was then outside the country. And she was told the moment she landed, no, she paid her when it was not even up to the end of the month. And I asked her to go, I will call you. I don't know if she's going to call tomorrow, I don't know. But you know, that is so something must be done. Like who is going to blow that whistle?
Okay.
What the policymakers, what are they waiting for?
Okay. All right. So I'll let her talk. Then I'll probably share a few experiences from mental health perspective to see what we can do.
Thank you very much. What I want to say is what Dr. Asiedu was saying earlier on. Because I think late last year we've had National Health Insurance is going to roll out the new policy on the diagnostic grouping. So for me, we have a gap as far as our discussion here and advocating for a particular therapeutics to be added or how to go on with this, because we will need to find out, because that's the policy going forward now with NHIS, because if we come to the diagnostic grouping, then we are no more going to be looking at the maybe four medications in a bundle, but we are going to look at the whole, diagnostic grouping thing, and also the client to be managed as such. So I think there's a gap there that we need to explore with the two policies. You are not too sure what I'm saying. NHI is like currently as it stands, the four medications for years. So as he said, that can be used. But the policy is now changing or has changed. You see? So probably we need to go back. That's what I think. We have to go back and look at what is in this for epileptic patients, what is in this policy, new policy that NHIS is enrolling. I don't work with NHIS, but I was at the stakeholders, meeting like this one, So we are moving forward in a different direction, but we don't have that information here now.
Okay.
That's what I'm trying to say.
Okay.
Thank you.
So I think it's clear now that we don't have the information on the new policy direction for the Health Insurance Authority, so that we can use that as a basis to push for expanding our reach.
Okay.
Yeah.
But before we even come to NHIS, I want to say KEPRA is not part of our EML as it is now. So it has to first go on the EML, go onto the STG before NHIS will even look at it.
Okay. All right. So now the question obviously is, who bells the cat? Because we can talk and give all the great ideas, but eventually have to decide who is going to be pushing this. So
there's a process. There's a process. The first thing is that if a particular medication is going to be introduced for a certain diagnosis, colleagues may be using it. But if you take the standard treatment guidelines, that is not what we are supposed to use. So it first has to become clear that this is the direction we intend to go. There's going to be an HTA for it, Health Technology Assessment. That is done by Pharmacy Directorate in the ministry. Then from there, it will be captured as part of the essential medicines list. Then it will go into the standard treatment guidelines, as she said. Then when you then National Health Insurance will pick that and put it into the benefit package. That way, when you prescribe it, then insurance will pay for it. So this is how the process is. That is why I was a bit concerned that maybe they came in the morning, or maybe we missed, So I will take this. It means that after this program, we will take this up, engage the Pharmacy Directorate of the Ministry of. I know you invited the ministry, but
did you say you take it up?
I'll take it up.
Okay. Just making clear of that.
Oh, yes. That's why I'm here. The people will be wondering whether we've solved the problem. No, I'll take it up.
Okay.
I'll take it up. So when I go back,
yes,
I will have a conversation with the Pharmacy Directorate in the process of including some of these things onto the essential medicines. If Ghana considers a certain medicine as essential, then that is where we can get it onto the benefit package. So I'll take it up. Whoever is supposed to be, I'll take it up. Then we can start that engagement.
Great.
If the whole process can stay.
Oh, it takes time.
I'm only.
It's not going to start with tears.
Experience with maybe other medications.
Oh, I don't want to promise because it is not in my under my care. But I'm in the technical coordination directorate, and the head of pharmacy is my colleague. So I will take it up with him, and then we'll give the feedback. Yeah, thank you.
And to add up to it, once he's willing to take it up, it's something that, from experience from the mental health perspective or side, that one person will still not be enough. There should still be a push from the associations. That's talking about collaborative I don't know if I mean, we all celebrated when suicide was eventually decriminalized in Ghana. That work started more than 10 years ago. And back then, there were just like one or two of them. But when the associations started giving the legislators pressure, they realized that they have to give in. And so it means that all the stakeholders here involved, various groups, CSOs and all that, will have to come together and say that this is a direction we are all pushing, that maybe by the end of this year, we should have made some progress with making sure that we've expanded our drug options or treatment options for epilepsy. But mind you, it's not just epilepsy you are looking at. You are looking at neurological disorders in general. Okay. Then, with regards to the policy and legislation, I side with you. I actually agree to, but that's why I was looking at it from both ends. Again, from experience. You know, now we have a Mental Health Act, right? The reason was that in the past we had bits of mental health law in various legislations and all that, but it was still not really solving the problem. Even up to now, even after it was from 2012, right, to now, we still have judges who do not understand the process from fitness to plead to capacity and consent and all of that. But at least now we know that we have a law that you can look at. But then back then, you have to know which particular law applies and all that. You are combing through the laws for it. But here you know that now you have one place where you can start from, and then now you can apply the other laws in light of this. So that's another idea that we can still look at, that we can still have a policy that links to the others. And again, yes.
No, I don't think it's a problem.
Yes.
Because if you take, let's say, so policy becomes a bit polarized.
Yes.
So we consider neurological disorders, let's say,
yes,
as a non-communicable disease.
Yes.
We will tease it out and say that we're developing a strategy for epilepsy.
Yep, exactly.
For example, we are currently working on oral health.
Oh, sorry, I should have given you.
We are working on oral health strategy.
Yeah.
We are looking at the eye policy, which is teased out from the non-communicable disease policy.
Yeah.
We are looking at national cancer prevention and control strategy. We've done the sickle cell strategy. So
we can definitely.
I don't think it's we can develop strategy. Because sickle cell is a non-combative. We've been able to tease it out, developing something on it. So that should also not be a problem.
Is there
we can work together.
The Neurology Society. No, here. Okay.
So I'll leave my contact. If we find anybody, let them come to the ministry
to work on that.
Then we will do something on that.
Thank you very much.
Thank you.
Okay. Then, so we're doing policy and funding. Yes. So aside the funding for medications, I'm sure the other aspects of care. For instance, talk about the cost in terms on caregivers, for instance. So how do we tackle that as well in terms of funding and policy?
Of caregivers. Okay.
No. So caregivers of persons with neurological disorders get no support or funding support from government or any other source.
Well, I know within the district assemblies, if the household or that individual registers with the district assembly, acknowledging that the person, they use the term disability. So I think they get some occasional source of some occasional funding or disbursement or some means of livelihood. Maybe they buy a fridge for them or they put them through trade learning and stuff like that, but not like a monthly stipend or anything like that for the household, except registered probably under if that same household qualifies to be with on the LEAP, then yes, otherwise that's it. Thank you.
Right. Okay. Is that the rest of us do not have any views on this? Because like it's a fixed number of.
So let me also mention, so this is where the integration comes in.
Yeah.
Even though we are also looking at some
Yes.
standalone. So currently, as I said, we are doing the impact assessment for our old cancer prevention and control plan, which ultimately this year we are hoping to revise it. Now, what is happening is that we have looked at financing aspect of it, and we are looking at the direct and indirect. You know that some chronic diseases, the people cannot go for care alone. Now, one of the things we are looking at, that out of this, is it possible? Because if you are migrating it onto the Ghana Medical Trust Fund, initially the thinking was for treatment. They say, who is going to do the treatment? So we need to build capacity. Then when they build that, how do you make the diagnosis? We need some equipment and diagnostics. So we are also thinking through, because the law has been passed, but trying to expand how we go. Say somebody is going for care, there's a direct cost which they're going to fund it, but it doesn't go alone. Somebody accompanies. It's possible that you are coming to Kolebu from a certain place. Not that you don't have a job. You already have a job.
Yes.
But you have to accompany your family member to come to say Kolebu, and then you are there for 1 month. What is going to happen to you? You have left your job. Are you going to lose the job? Because, for example, our brother gave that example that because of people being afraid, thinking that, so you've left the job and you have come. Are you going to be paid or you're not going to be paid? So these are things we are even trying to add on to. So when we talk about financing health, the indirect cost, one, for the patient transportation to the place where they are going to procure the service, and then two, the accompanying person who may have to leave the place, come and look for accommodation somewhere, leaving the job because earning that income, somebody's going to take it away, and then doing advocacy for employers to understand, even if you are not going to pay the person, the person should not lose the job. Because so we are looking at it holistically, looking at the technical or the clinical part and the soft part that accompanies care. So all these things we are capturing it and expanding that scope to include whether somebody is going to pay a salary is another conversation. But we are minded to know that the indirect cost sometimes can even be more than the direct cost. And we are minded to think about that. Similarly, so what I was talking about was, say, for the cancer. But where we do the integration is that they are all non-communicable diseases. If somebody has, say, a seizure that is very difficult to control. I have a friend and a patient that we are managing. She can have the seizures almost every day or every other day. She's in school. How many days she's able to stay in school? And then, because in the school they are a bit concerned, so they bring. Then the mother has to stop. She was actually working, was gainfully employed as a manager in one of these hospitality industries. But every day your child is having a seizure, you cannot continue to go to work. And sometimes your boss is a bit uncomfortable. I cannot understand. Are you the only person that every day your child is not well? And if you are not working, why should you be paid? So I feel very bad. I'm not the employer, but I feel very bad about it that, so these are things we are looking at.
Thank you very
the
much.
human side of it.
So there's the opposite direction of the advocacy that I think we should look at. So she mentioned, for instance, that there is opportunity if you are the assemblies, the local governments, to get some support by reporting or filing or applying for disability. How many of our lived experience persons are aware of this and are taking advantage of it? I don't know if any would want to comment on that.
Thank you very much. I think in Ningo Pram Pram, it took
You have to speak up a bit.
I think in Ningo Pram Pram, we took this initiative that was 4 years ago, where we had a lot of patients who can't afford their medication. And so we partner with the district assembly and then we registered them. So what they did was that they asked you what you want to do or what the carer want to do, and then the money is given to you to do that particular thing, and then we report with pictures But currently, what they do is that they are not giving the money. But if it is a trade, they want to put you into that trade. So that's what they are doing. And then I think NHIS also has come up with a free registration and then renewal with persons living with epilepsy. And so we gather the list and then send to them. They give us a day to do the registration for them free. That's what we are doing. But I have another challenge concerning the medication. I'm a mental health nurse, and I realize that the medication that comes, like the program, the NHIS, sometimes is of low quality. There are clients that does not do well at all on it. And then when we give to them and the condition worsen, they don't come to the hospital. And it becomes a challenge. And so what are we doing? Even though NHIS is producing the medication, at least it should be of quality that can support. Thank you.
All right. Thank you. You have a comment on that?
Yes, and I think that I love your presentation, the things you said. That is why, and I think you made mention, that is why we should widen the scope. Don't keep the people on only 4 drugs. Why? Why are you keeping on for where there are over 50 anti-epileptic drugs? That you can spread the thing. Because if I'm telling you, and that is exactly what is happening. That is exactly because I see people, I speak with them, we sit, we talk well, everything goes well. They go to the hospital. Sometimes I take them personally to the hospital, and then they are happy, all the things that the doctors will do, diagnosis and everything. And then they start taking them like 1 month, 2 months, 3 months. You call them, they are not even picking your phone. It is because they've taken the medication, it's not working. They are believing what the pastor is saying. So before you know, they will go and stay in that church house and their problem worsen because we have just been restricted to medications that is not being compatible to other people that we bring. Yes, some have worked on it, but some they are not working at all. And I think that it is something we need to, the policy that needs to be made to make this thing, because I've heard before Dr. Apalu, before Dr. Ajay before they became prof. This thing, we've hammered it several times. So when you go to Ministry of Health, you see that mental health case is blown. Epilepsy case is in one corner. So we never get to deal with it. And we go and come every seminar. We'll talk. But I think that it is time we let whoever is in charge to widen the scope as far as medication. For medication, what are you talking about? Like you are joking. Because we never get to solve the problem. When you give them medication they take and it's not working, you don't have the solution. Because you see, when you go to Confanoche, you have Dr. Ruth, and you know what somebody to another person says, Doctor, no kwa epilepsy, why? Because he's using some cool skills and medication, and it's working for the people. Medication now working and control be do you understand me? So that is what, and then concerning taking care of caregivers, that is a very dicey situation. Okay, I have gone through past, and I have gone past that stage, and I can understand the woman's, somebody is working with you 4 months, the man himself is working, but they have not been paid. He's even lucky he's able to work. Some cannot even work. 4 months, so that thing we also need to look at. There are some. The person is working. The man is working. He stated that he's working as a security man. He has worked for 4 months. Your employer no no. Me penny ni mahwe. Ontua papa no. And to me fast can be if you ban sa ema burden ba mamenu so. So we also need to have a clear cut as to what can be done. Maybe I might not need it, but somebody needs it. And these things are part of the factors that will encourage the people to be, because and we also need to be careful in putting up those policy. And yes, everybody will be careful.
So that's a good point. Now, when it comes to the medication, another point I think I should draw attention to, which also comes in terms of advocacy, capacity building, is that from experience, sometimes the issue is actually the client or the patient understanding the process of treatment, and also the physician or the prescriber knowing when and how to increase doses. Okay, I'm saying it from experience that sometimes you would have, when you start, usually start a lower dose and then gradually pick up. Now you start on say commencing 200 twice a day. Commencing in such a way that it breaks down, it begins to break itself down over time. So you need to rapidly increase the dose. If you don't educate the clients to understand that, the seizures may reduce, but may not stop completely on the first dose. So if after 1 week, 2 weeks, you are having fewer seizures than you used to, but you're still having seizures, you come for us to adjust the dose. Then they say that I'm still having seizures, so I'm not coming back. That is one. The other thing too is that sometimes we are also too afraid to increase doses. So somebody has been on carbamazepine maybe 200 twice daily or whatever. They are still seizures, and the person is on the same dose over and over. And that's where again, because you don't have so many neurologists, sometimes people are scared. I mean, it's genuine concern. If it's not your field, you increase the dose at some point, you are taking responsibility that is beyond you. So how do we link the neurologists to those are the primary care? So I can at least have some support in understanding that, oh, I can now increase the dose, I can do this, I can do that. So those are some of the areas. So you realize that even when we're talking about funding and policy, it still comes down to advocacy to make sure that even the little funds and little policy that we have already running is working. I think you had a comment to make.
Medication alone
Yes.
can also even affect how it works. So it's not about the medication not being effective. It's like Dr. Chawe was saying, it's a process, and he has explained. You have to increase and taper it. I mean, it has to be titrated based on the patient. So the fact that the first dose you took did not bring it down or stop it doesn't mean the medication is not effective.
Right. Thank you very much. How are we doing with the topic?
I think what we haven't really covered is now the who. So in terms of all these issues, even the issues around
Yes, we have one who. It's left with the rest of the who's. Yes.
The strategy,
Yes.
a strategy for epilepsy and neurological disorders is still the who.
So that yes, him, and then as I mentioned at the MOH, the societies and so like,
finances or funding, and where will that come from?
for which one?
Especially for the strategy.
Oh, so the funding for the strategy.
Because it seems like it's a document that will need to be developed over time.
So, well, yes. So who is financing it? Any ideas? Let's. I think those are the main ones that we need to have ideas on. That we can round up.
Yeah, I think so. Finances behind it. Those are the two things we're not really.
My boss from WHO is here. If WHO will find what. We are talking about pushing for policy and also pushing to have the neurological disorders like epilepsy and their treatments expanded in the guidelines. And we were told that through the process, we need funding. And
There's an ongoing review of the national standard treatment guideline.
Yeah.
And we've included sections on Parkinson's.
Okay.
And yes, there was an advocacy for that from the last IGAB meeting we had in 2022. Okay. So that is ongoing, and indeed expanding even the national treatment guideline to capture some of the neurological medicines for managing neurological conditions. So that is ongoing. The problem with the standard treatment guideline as it is that WHO supported with the NCDs and mental health components. The other components, they're having a challenge getting the experts to review because it's also cost intensive. So they are trying to do it in batches, which is dragging. That's where the challenge is. So in terms of integrating, yes, it is ongoing.
It's ongoing.
But it's at a snail's pace because of funding challenges.
So the funding challenge is still
it's still and now everybody understands that in the global space, funding is a big challenge. There are cuts from donors everywhere.
Okay. Last question.
Rounding up.
Yes, rounding up. That's the last question.
Thank you.
So from that perspective, looking at from 2022, or which groups or organizations or individuals were identified as people who can lead or should lead some of these tasks, like pushing for the guidelines, like you said, policy, legislation, things like that? From my experience from mental health perspective, it looks like it's mostly the associations
society,
and the
professional
professional groups. But in neuroscience, when there are only about 16 of them now, is there any way we can get other people to push them? Maybe we can partner. I mean, there's still brain health, so we can partner.
Oh, yes.
Psychiatry.
So I think we can
psychology.
look at the spectrum of mental, neurological substance.
Yes.
I mean, the broader brain health.
Brain health. That's it. Maybe we should look at it from brain health perspective, and then we all come together and push.
And then stress more on the preventive.
Yes.
Across the life course, making everybody included as beneficiaries or potential risk groups, so that everybody feel that they are benefiting.
It's true. When you let the politicians know that they can also have the same disease,
Yes.
then they are more concerned. I agree. Oh, he said hello. We just wanted.
I'm just curious because when we were here in 2022, there were groups looking at enabling medication production in country. Did anything progress from that? Has anything progressed from that? Because supply is a real issue, isn't it?
Yeah.
Especially if you're relying on outside country.
Yes.
Oh, you want me to still? No, but local production is top on government's agenda, especially with certain medications that we feel that one, in terms of the consumption, and then also opportunities for good outcomes for this. I know is top on the. I'm actually chatting with my colleague now in the office. So tomorrow, NHI. No, tomorrow NHI will be here because of the conversation. So I just spoke to somebody will be here tomorrow, and then I will also talk to pharmacy. But National Medicines, the National Medicines Authority will be here. National Medicines Authority. Okay. National Medicines Authority. The Pharmacy Directorate. The one at National
Medical stores.
Oh, medical
Is it stores? Medical stores.
Is a temporary.
The lady was here today. Oh, she was here today.
Okay. So it's on the agenda.
All right. Any last word, or we can conclude now?
Charles had that. It's Amanda.
Okay.
Okay, I also think in terms of the education aspect, we should have.
I can't hear you.
Hello.
It's not a mic. It's just for recording.
Yeah, for the media team. So
I believe in terms of the education aspect, we should have videos in the local languages. Twi, Ga, Fanti, Dangbe, Ewe, and that will really help.
Yeah.
I also want to add that we should focus more on the awareness creation at the household community level, especially among the teachers, the school children, and I mean, so that it will help in the case detection, then follow up through to treatment. Because at times during home visiting, you might go and find somebody who has just been. Meanwhile, that person could have had care, So then we can also bust the myths and things concerning epilepsy. Thank you.
Yeah, thank you very much. So
there are two hands up.
She have not heard from me, so I'll let her talk. Yes.
Hi everyone. Thank you very much for the opportunity. This is actually my first time engaging in conversations around.
She's a graduate student, right?
Yeah.
Okay. Engaging in conversations around epilepsy Yes, I've never seen any meeting or conference happening like that. So I'm just grateful for the opportunity. Again, so this is my first time hearing that there's a fund allocated to people living with epilepsy. And I think the advocacy around that can really be intensified because if people are not aware of it, how do they even access it? And even in terms of access, what's the process like? And so this is something that can be taken up from here. And then in terms of intensifying that advocacy, I just want to reiterate what Madam said, that it should go to the grassroots. People are not even aware that such a thing is happening to them. Yes, thank you very much.
Thank you. Last one, 2 minutes. No, 1 minute, 30 seconds.
Make it 5 seconds. Okay.
5 seconds, yeah.
You see, with what my patient said, I think that and then her sister, it is high time we translate these things down. And aside translating down, consistency has been a problem because I can tell you, there was a video we did with Ghana Actors Guild. Dr. Cynthia Soti was there. Do you understand? And that was one of the videos I was using when I go out for advocacy. Let me tell you, they show this video 1, 2, no, they stop. Like when I mean they stop, I'm talking about the media houses that are supposed to show. And before they show, everybody wants to collect money. They have no passion. And I repeat, they don't have passion for. Because even myself, the people I stand with as executive in IBE, they don't even have interest in what is going on. Senipano, even the one that has epilepsy, who is one of my executives, doesn't have interest in what is going on. I am telling you the gospel truth. Okay, I don't want to loud down. Don't go and tell her I said it all. But that has been the challenge. So we need to, if we should come out with any video, we need to follow up to the letter. Because last year we were at Aikuma Shai Osudoku, and then we deal with all the school heads and one church. It was food, but you ask yourself, is the thing being continued? The people that are sitting there, do they even have passion? If you don't have passion for dealing with epilepsy, go and sleep.
Yeah.
Yes, it is very, very important.
So,
let me make some.
Come again.
Please, you should be nominating your person now. Kindly be nominating the person to speak.
Okay, you can nominate me because I'm going to be coordinating. Yeah. Yes. Yes, just quickly.
Thank you very much. I'm excited to be here as well. And like my colleague said, this is my first time interacting with epilepsy and all of that.
Yeah.
And it's been really eye-opening as well. So with regards to what you were saying, I was just trying to recommend a strategy that you can use because you made mention of the media houses and all that. The internet has been the game changer. You can go on social media, work with influencers who probably have issues like that. You'll be surprised that there are people dealing with things like that. And you can sideline the media houses. Yeah.
Yes. So in conclusion, there isn't much money. Let's explore all options. And even on your own, there are things you can do without having a lot of money. You can talk at your church about epilepsy. You don't need money for that.
So I just want to bring to our attention again that we don't have to be disappointed in what, I mean, we are talking about 2012, 2020. It could have been worse if we had not put in what we have done up until now. At least I can hear 2 people saying that they didn't know so much about it. It means that the advocacy is
identified challenges. And we found, or we've seen that the NCD policy covers epilepsy and other chronic conditions. There are some drugs that at least four drugs that are covered under the health insurance, and that to a large extent is mostly carbamazepine and phenobarbital that are available at the primary care most facilities. But then at least there's been some progress in terms of coverage. And there's some sporadic support for caregivers, particularly from the local government level. And there are also efforts in some areas, districts and regions, for free registration of people with disability, including neurological disorders, on the NHIS to enhance their care. There's currently also ongoing review of the SDGs to capture wider range of neurological disorders as well as their treatments. And also local production is key on the government's plans in terms of bridging the gap. So local production of medications for neurological disorders. So for instance, I just said the carbamazepine, for instance, I think there's some local production of that currently ongoing, and we are hoping that that would expand further. The next question is that what actions are needed to address the remaining challenges? So whilst we were talking about having policy and all that, we came to the conclusion that there are existing policies that capture neurological disorders to some extent. And whilst having a standalone policy may seem ideal, it also may have challenges with integration. So we should rather look at neurological policy strategies under the policies, looking at the looking at neurological conditions. So looking at the NCDs, for instance, epilepsy strategy and other neurological disorders, strategies for epilepsy and other neurological disorders. And then looking at medications, again, expanding access and expanding funding for medications. Here, again, we'll look back at what has been done with the SDGs and then going forward. So the things that we looked at were also who should look at or handle some of these things that we've discussed. The major point we noticed is that in most times it is the professional bodies and the groups and organizations of lived experience persons. But in the neurological field, we tend to have very few neurologists, so already there will be a challenge there. And so we suggested that instead of looking at it just as neurological disorders or neurology, let's look at brain health, so we can rope in all others, psychiatrists, psychologists, anybody who works in the brain field. And that will give us a larger volume that can help us push for some of these things. So we talked about the processes that would involve getting some of these drugs. We talked about expanding the drugs. Some people have shown concern about drugs like Keppra and so on not being on the insurance, not even the generic. And so the discussion that we had on that was that it's cost intensive, but we'll have to look at going through the process of getting them some of these conditions, these medications on. But they also mentioned that sometimes the challenges, and we looked at advocacy here in this sense, that sometimes you're looking at advocacy upwards upwards towards policymakers and so on. But we also have to look at advocacy down towards care providers and then the clients, get them to understand that sometimes it's an issue of dosage. It could be an issue of follow-up, so that they understand that if they start on the treatment, the seizures may reduce but may not go away immediately. But then they can come back to continue care to ensure that they get the optimal dose. We should also focus on awareness creation, in our communities and so on. And sometimes we complain or we are waiting for enough funding to start doing a lot of things. But there's so many things that we can do on our own without necessarily having to have huge funding. You could, in your church, in your mosque, in your school, in your workplace, you can start doing small advocacy that may not require too much. Then we also look at what are the roadblocks to these actions and how can they be resolved. So of course, major roadblock to funding is funding itself. So we discussed that. One of the things that we can start doing is look at promotion of integration. They're already funding to some extent allocated for certain policies and so on. So we should push for having neurological disorders included in these policies whilst we are looking at getting standalone funding. And then one of the challenges is that if there are drugs that have been already designated as being free or supposed to be given freely, then there is a challenge getting it put on the NHIS or paid for. And so we should look at where we know there are going to be unsustainable expectations that certain drugs should continue to be free. We should rather push for them to put on an insurance scheme so that it's readily accessible and more sustainable. So we also looked at what are the stakeholders that will take some of these actions. So that's what we talked about. So we talked about Ministry of Health, Mental Health Authority, National Health Insurance, Ghana Medical Trust Fund, and so on. And then we said that most of these organizations or most of these agencies will not work or will not do what we expect if we do not push. So all of us here, wherever we work for and whatever organization you are representing, also have a role to play in pushing. Then what are the resources needed? Well, it's still funds mainly. So we talked about some of these things coming on the insurance. Timelines. The timelines are not clear, but looking at the schedule and activities, at least within a year, we should have made some progress, particularly for those ones that are already rolling out, like the STGs and the review of the health insurance. So those are things that we should be able to do within the next year. What will success look like, and how will we be measuring that? So we are expecting from our discussions that at our next session, when we next meet like this, we should have clear strategy at least for epilepsy and then other neurological disorders. We should have inclusion of or expansion of the drug list to include other drugs like levetiracetam and so on that may be of use or benefit. And then we should also now be looking at brain health and prevention rather than just talking about brain disorders or neurological disorders, but brain health and prevention so that we have less work in terms of managing diseases because everybody or most people have sound neurological and mental health. How will progress be followed up and monitored? So again, those are the indicators that we've talked about. Looking at the inclusion of more medications, levetiracetam, lamotrigine, and so on, that are other useful options. Then the integrated strategy for neurological disorders, we are expecting that at our next meeting, we'll be gladly saying that at least we have a clear strategy on neurological disorders for the country. So that's the work so far from Group 1. We want to emphasize again that it doesn't cost money to talk to somebody at your church, at your school, in your workplace, or on the streets. And so whilst we're waiting for big funding to do big things, we can do a little that we have for now. Thank you very much.
Group 2, and if colleagues also have questions for Group 1. Any question? It's either he did a very good job or they did a good job or they didn't do it. Okay, well.
So if I understand, I got you, that usually when drugs are produced locally, they become expensive. Okay, I will let a rep from your group, but just before that, I think that one pushing for government support policy is one. The other thing is that if we are sometimes the reason or the factor that contributes to the cost is it's a numbers game. So we could look at expanding the reach to the sub-region so that we have more people being covered or more people taking the medication so that now it can drive the cost down because you have a larger base you are supplying. So more or less like the supply and demand aspect of it. But I'll let the experts talk more on that.
I think you've answered the question, but I'm yet to really find which drugs Prof is talking about that are more expensive. The locally manufactured ones are more expensive than the local ones. Prof, please, do you have some examples to give?
Oh, thank you. But you see, you're asking me back a question, but I needed an answer for that one. It's very, very important because these drugs, by the time they are able to come out, the cost per pill will be similar to the one you've already imported from, say, India or even the ones they get on the market like British generics. So I think that when we are looking at getting these drugs, maybe still back to the ministry and the NHIA. If we have a national health insurance scheme and then they know we have 1 million people registered, any drug company, if you present your, you don't even need to go and get a local one. You can go to Pfizer, you can go to Novartis and tell them I have 1 million people sitting on my data who need your pill. They will give you the same drug they give to the British market at a cheaper cost because it will not be labeled as such. It will be labeled as Ghana brand. So I think that's the way we should look about local manufacturing. By the time you import a machine to cut the pill, it makes it too expensive. I can only compare. A bottle of Casaprecogen is equally expensive as buying a bottle of vodka. And people prefer to buy vodka from anywhere else than buying Casaprecogen. Thank you very much.
Yeah, so thank you very much. Just to add on to, but the part that Prof talked about in terms of the opportunities to negotiate a good deal, already Ghana has it on the Pfizer Accord, where medications that were selling as high as, let's say, 6,000 Ghana cedis have been reduced to less than 1,000 Ghana cedis. So, and then also medications that hitherto would have taken 2, 3, 5 years before they get to us here are getting to us in the same time that they are launching the medication. So that pool procurement system is happening in Ghana, and we are capitalizing on that one to get medications, high quality medications at the minimum cost. But again, what my colleague here was talking about was the fact that the medications that we produce here are relatively cheaper. Now, in our group, we're discussing issues around the quality of the medication. Unless the medicine is passing through the back door, Food and Drugs Authority will make sure that they meet the minimum requirement in terms of that that is there. So the medications, both the ones that are locally procured and the ones that are imported from elsewhere, at least once it passes through Food and Drugs Authority, they will make sure that they meet the minimum standards to do it. Except that the medications, different people react to different brands. And since we are working towards having a generic medication, it may vary from person to person. Maybe the one that works very well for a certain brand working very well for this patient might not necessarily. And I think it's important for us clinicians prescribing and also working closely with our colleagues who are dispensing those medications will be able to find what works well and what doesn't work well for each person so that it's categorized and managed as such.
Thank you very much.
Just to, no, so thank you very much. It's an excellent summary. Emmanuel's got his work cut out. But so in terms of the medications and local manufacture of medications, the quality control, as was being alluded to just a moment ago, is critical. And it might be that rather than local manufacture of lots of medications, that you look to regional manufacturer. So that there's one centre, for example, in West Africa that generates most of the medications, and that may be cheaper than bringing in all of the branded generics from India, for example. But because a lot of the cost of the branded generics is taxed on every time it crosses border, there's a tax implication as well. But that wasn't the point I was going to. Actually, the point I was going to make was about the idea of involving local churches and local sort of communities, youth groups, and so on and so forth, because our team talked a lot about how you can involve and empower the local community. I just wonder if you thought how that was going to actually play out in practice, and how you were going to metric that actually made a change. Thanks.
Did we get Adam?
Why didn't you say you couldn't hear me at the start, right? So, okay, so you want me to repeat it?
Yeah, just quickly, the question again.
Okay. Can you hear me now? Yeah. So the question bit was about the community engagement of local communities, churches. There are lots of churches even in Accra, other community groups, and because we had talked about that as well. So I just wonder whether your group had thought about how you were going to do that and how you were going to metric that it had made a change.
Thank you. Anybody wants to respond to that? The local churches, the communities, how we are going to metric that, and did you factor that in your discussion as well?
So
maybe group members can answer.
Maybe I'll start the add up.
Okay, please.
I'll do the easier part, and they can take the harder part of the question. So, for being able to measure or know how you're doing it, again comes in terms of the organizations and the groups involved. So if we have an organizational drive over a period, so I give a typical example in mental health. We usually say, we used to do October, but the breast people were fighting, were fighting for the space with us, and we can't fight breast. So we moved to May. So we do Purple Month in May, and yes, we have advocacy throughout the whole year, but May is the drive month for mental health. And so by the time we are done, we can see that because we are actually going out and it's well structured and organized, we can see that we've done this number of schools, we've done this number of churches, we've reached this number of people, and so on. So having a coordinated front, that I think it looks like we are putting a lot of burden on or expectation on the neurological society, but it looks like they will likely have to be the ones to lead this so that we can have a well-organized, well-coordinated approach so we can know who has talked where, what the person said, if it's appropriate and all that. Then in terms of measuring the outcomes, I'll let my team answer.
Okay. Anybody? Group one? It's for advocacy, whether there's a measure or a metric for it.
It hasn't been much, but it's been good. So if I want to look back to 2012, officially what has been done in the country till now, individually, and then what we even started doing before now, I can say that a lot has changed, a lot of perception and a lot more people, because when I remember that time, there were a lot of people I knew who want to marry, their partners had, I'm not the only person who is married to someone who had epilepsy. I know people that I have to sit with them and share my experience with them. And that motivated them too. So if we kept all these things, or I've kept all this information for myself, I don't think I would have been able to record this kind of. And now a lot is being done positively to change the narrative. And I keep saying that there are more people who are being born. There are more people who are yet to hear what we are doing. So yes, a lot of success has been chopped, and we have room for more bigger improvement.
Okay.
Thank you.
Thank you.
Thank
Just
you.
quickly add up to that one. One of the simplest ways, one of the ways easiest for, at least from my side, from where I'm coming from, is that usually when advocacy is going well, the number of cases begin to rise. So it rises to a point, then it begins to plateau and then decline, because now people are becoming more aware. So for instance, when we decriminalize suicide, the following year, by halfway through the year, we had more cases of reported suicide than the whole previous year. And some people got started and said, you see, we told you that if you decriminalize suicide, they will do it more. But the reality is that now people are more aware and they are reporting. So we actually have data on how many cases, for instance, of epilepsy we are seeing now over a year period. The next year, we are seeing more people reporting and getting treatment. That is in itself an indication that we are making more progress.
Please, a round of applause for.
Okay, I also think that the advocacy is going very well, because in the Ningo Pram district where I practice, we have instances where the prayer camp leaders or the pastors will even bring the cases to the facility or refer them and even follow up with their medications. And so the advocacy is going on. Thank you.
Thank you. Thank you, Group 1. A round of applause, please, for Group 1. Group 2, please. Your nominee for Group 2, your nominee.
Okay, so we had discussions around beliefs, stigma, and discrimination in regards to epilepsy. So we had a number of questions to deliberate about in the group. The first was to look at the progress that has been made in terms of to reduce issues around stigma, discrimination, and those beliefs around epilepsy. And the group came out with very actionable points. One is the fact that there's now a lot of education. Professionally, there's now a lot of education around epilepsy. We see a lot of documentaries, a lot of ads regarding epilepsy, discrimination, and then stigma. We have also seen that there is, in terms of advocacy, yes. So there's also a lot of growing research evidence around epilepsy. And in the recent one we did, an example is what we did in the Shao Sudoku and Ningo Pram district, where we reached out to households, we spoke to them. So to some extent, issues around stigma, they know that the disease is curable, the disease is a medical condition, it's not spiritual. So a lot of issues around stigma, around that aspect is going off. So that's the progress that the group thinks has been made with regards to that. Then we also look at some of the roadblocks around the beliefs and stigma. And one is the deep-rooted cultural beliefs that we see around epilepsy. We see that there is a lot of deep-rooted cultural beliefs and practices around epilepsy. So that's, to some extent, continue to influence or continue to inhibit against the progress that is being made against. And how do you combat that? There's need to be a lot of education, continuous education to these people, continuous engagement to reach out to these people so that we are able to overcome those deep-rooted cultural beliefs. Then we also look at cultural key stakeholders with regards to this. And we look at the Ministry of Health. We look at the Ghana Health Service. We look at the hospitals. We also look at people living with epilepsy, their caregivers, and then the traditional leaders in those communities as our key stakeholders that will help in terms of trying to combat issues around stigma and discrimination. Then we also talk about the resources that these people will need to be able to effectively discharge their duties. And some of these resources include we need a lot of funding. We need to develop a lot of training materials as well for primary healthcare workers to be able to educate them. We need to empower these people living with epilepsy to be able to come out and then speak, just like we saw this morning that Mr. and Mrs. came to really speak about their issues openly. So in that aspect, you have empowered them to talk about their conditions. So they will now be able to, now they have accepted that they have the condition. They will now take or make efforts to really try to combat or go, they'll make efforts to look for solutions or treatments for their conditions as well. And then we also finally talk about what success will look like in terms of beliefs, stigma, and discrimination. And then some interesting points came out from the group that once we all begin talking about epilepsy, just like we are doing in this group, then we know that we are getting somewhere. Because once it becomes an open discussion, there was an example that was given around the HIV AIDS, where there was a lot of advocacy, especially in Ghana. There was this ABC of HIV, and it became the advert became so common in the society that people were no longer afraid of epilepsy, of HIV. They openly talk about it. People could go to pharmacies and then get condoms, and that is how we begin the whole process. So there need to be a lot of advocacy, a lot of talking, a lot of discussions around the condition. Then once we begin to do that, we'll be able to take the condition out of the shadows and improve issues around the stigma for those conditions. And then we also talk about how do we monitor, or how do we follow up, how do we measure success? And we are saying that once we see that there is a reduction, there is a narrow treatment gap, then we can say that yes, now people with the condition are now assessing treatment. Once we do like what you did with the EPINA study, we do a study around epilepsy. We look at the prevalence as compared to what has been done previously, and we see a decline. Then we know that there's an effort to reduce the burden of epilepsy around. And then we also talk of national surveys on knowledge, attitude, and practice. So once we do these surveys and get what people are saying about the condition, then we know in terms of their beliefs about the condition, then we know that we are making progress in terms of reducing stigma and beliefs around that. Yeah, so this is what I'll be able to capture if the group, unless something that the group can chip in.
Okay, thank you very much.
Yeah.
Okay, thank you very much, Mr. Emmanuel. So, any question? But maybe before then, maybe let me ask my question first.
No.
Then we can go on. AI has proven to be very transformative in a lot of spaces. And now I know even in advocacy space, people use it. Well, in a way, some as personalized tools for patients and getting to know what we have to do and so on and so forth. Also with social media. I was expecting to hear something around that in your group and how you're using it in the advocacy space. So that's my question. Any other question, please? Particularly from group 1 for group 2, if you have a question.
Yeah, with regards to that question, in terms
Yeah.
of combating, I think there was issues around that we said that we can use social media a lot nowadays to even reach out to a lot of people. I do a lot of content creation and then put them on these social media platforms, which will really go out and reach out to more people, and that is something we also mentioned in the discussion. So I think it's also considered.
Because today I really felt touched by Madame. Sorry, I've forgotten the name. I don't cry. I don't remember the last time I cried, but I thought that I was going to cry today when I heard her speak. So I think that was very good content. But how that content can reach a lot of people, particularly the upcoming generation, is something that we also need to think about as going forward with the work. Any question from group for group 2, from group 1? No question. Oh, it means they've done a very good job. Please, then a round of applause for them. Thank you very much. Thank you very much, Mr. Emmanuel. Thank you. Please, we need to capture Mr. Emmanuel and Dr. Richard. We'll be grateful if you could just send us or put them together, summarize them into key actionable points for us, and then we'll put it together and report on it tomorrow for everybody to have an understanding of what we came out with as a group based on the 2 workshops that we have just done. Thank you again for coming. This brings an end to today's session. Oh, I'm sure you're happy. So please, let's give ourselves a round of applause. Thank you to our partners for coming. Thank you to the EPINA team, both global and local. Everyone for coming to share your opinions with us. We meet here again tomorrow. And tomorrow, we are going to talk about access to treatment. So basically, let me pull the program for tomorrow. The subheadings for tomorrow, and then we have information also for part of tomorrow. So tomorrow is also packed, and we'll have our workshops as well. So please, we encourage everyone and then all others to come. We're going to have the health insurance and other key people here to address some of the concerns we have raised today, particularly around the cost of medicines and how this can go into the health insurance scheme. So please, we encourage everybody to be present tomorrow. As we close for today, just a few announcements as well. Someone left something that's very valuable. And if the person doesn't want to be divorced, please, you have to see me. You left your wedding band. And I've seen, I don't know whether it's a female or it's a male, but please just get in touch. Identify the band. And if you don't know your band, then there is a problem. Then I will do what I need to do. Then I have to do what I need to do. So thank you very much for coming, and we are most grateful for your time. Have a good evening, and we'll see you tomorrow. Thank you. Who is he? Oh, yeah, yes, I'm going here.